Well, welcome everybody, and thank you for coming. Tonight, we've done some of the introductions. Like I mentioned, we do have an OR SIM team, some of whom couldn't be here tonight, but they're still a big part of helping me get everything organized and together. But there's also so many people behind the scenes that helped make today happen, so sorry if I've missed anybody. But as you can see, half the people in the room are actually people that helped set everything up. And thank you to Darren and Jack. We are planning to stream this on YouTube. So I'll mention a few things about that as we go along, but just a reminder that there will be cameras, and so try and, if you can, orient the action to allow the camera to have you in its view.
Which is my good side.
I would also like to welcome Danielle. Dr. Meunier is going to be helping out tonight. She is a hematopathologist from Victoria, and she is on call for the blood bank tonight. So if and when you need some assistance, or if, for example, an MHP were to be called tonight, I'll ask you to give Dr. Meunier a call. So I don't know if a couple people maybe want to write down her cell phone number, or take a picture of it perhaps, just so that you can contact her in real time. So we can either call her on your own cell phone or on the hospital system's phone.
On speakerphone.
Mm-hmm. On speakerphone would be perfect.
Probably would not have any blood transfusions, so I would.
Oh, maybe not. So in terms of the accreditation of this evening, these are the official learning objectives. So demonstrate skills in managing emergencies. Well, there might be an emergency or two happening tonight. I'm going to encourage everybody to focus on using your crisis resource management skills as we go along. I'll touch on that in a bit. You are welcome to use whatever aids you ordinarily would use to help out in an emergency. So if you found that there was something that would be useful to you, feel free to use it and refer to it. Tonight we're going to be doing a lot of interprofessional communication, and specifically for tonight's learning objectives, we will be walking through an MHP. Sorry to spoil the surprise. We are also going to focus on communication, because we're so many different departments that don't always work together. There will be transition, there will be handovers, and it's a great time to practice that communication between different departments as the patient moves from place to place. Another sideline that I hope comes out of tonight is to learn how we can support each other with these really challenging cases that happen in the middle of the night. So I know that for me it's been really helpful to have extra sets of hands in the operating room, for example, from Emerge or ICU. But radiology is kind of isolated. So how can we help radiology move these patients through efficiently? Those kinds of things. And another objective for tonight is hopefully you'll have a chance to meet some new friends. I have no disclosures, except that it did take about 2 months to put this together. That's my only disclosure. So I made a mistake on this. It's actually 2060. We're in 2060, not 2050. This is an ideal sketch of what the night might look like, But in reality, it might not look anything at all like this. I'm hoping we're out of here by 9, but that might be wishful thinking. So what we'll do is start down in the trauma bay with a patient that is just on his way in to emerge. The plan after the trauma bay is to actually physically move that patient from the trauma bay up into the OR, and we're going to be going to OR 8. From OR 8, after the surgery, we're going to be moving the patient down to radiology to complete all of the scans that they didn't have time to do before rushing the patient to the operating room. Once the patient is finished in radiology, we're going to move that patient, still actually the real live mannequin patient, from the CT scanner to the mock ICU. And actually we're using the radiology holding bay as the ICU. After that, the most important part of the whole night is to come back here and we'll have a debrief of the whole entire evening. So tonight is going to look so much different to the way that we usually run simulations. And for those of you in the operating room who have done sims with me before, it's not going to look anything like that. It's going to be total chaos. It usually is chaotic, but it's going to be even more chaotic, and it's going to flow through without stopping to do a debrief with each section. We're going to come back here and actually debrief the whole thing, if that makes sense. Because there are so many of us, the flow is going to be like this. We are streaming this on YouTube. So I'd like some people to hold back in reserve if you're not actually going to be participating in that particular section. The first section down in emerge, I would like anybody who thinks they might possibly be called upon in emerge to head down there. That means that the OR group will actually stay here and watch it on the screen. But Jane and Martha, I'll get you to go down to emerge, and you won't appear until you're called for, and you might have to be en route for a bit.
Okay,
You can
we'll come from home.
I'm not calling either of you. You're just late. I don't feel like getting yelled at.
Because that's how I always am.
And as it turns out, Jane, there's not an assist on tonight. So you might have to help out Martha. So then emerge with some of us from the OR hanging out here. Then, as the patient moves to the operating room, all of the operating room staff and anyone who thinks that they might be called upon in the operating room, such as the ICU docs, will make their way to OR 8. And that means that the remaining emerge staff who haven't been assisting in the transfer of the patient will come here to watch that part on YouTube. The great thing about the radiology space is that we can all fit in there. It's going to be cozy, but we're all going to go down to radiology, into the CT scanner, and then we're all going to move to the ICU, which is just adjacent to the CT scanner. I feel like I'm missing something, Darren. There was...
On the sign-in sheet that you came in, hopefully you all saw that you were consenting to us streaming this. It will be held there as well, so that's hopefully just great for you. There's also a QR code on that, so if you want to pull it up on your phones, you can do that. We are hopeful that the audio is going to work out okay, and we need your help with that. And so the main conversation in the room about patient care and the collaboration around that needs to be heard, and the rest of the other things you might want to talk about, we'll ask you not to, because that's what's going to mess it up, is all the sidebar stuff. So So if you can, it would be great. If you didn't speak, you must, take care of Casey, which will be hard for me and I know maybe for you.
Yeah, so if you're not actually speaking to the group, then try to minimize the chatter. All right. I thought that was really funny. So I'm not going to go through my usual simulation spiel, which people like Amanda and Jess, who have heard it a million times, are going to be thrilled to hear that I'm not going to do it again. So I'm sorry for anybody who has not participated in a sim before, but I'm not going to talk about what simulation is. And I'm just going to say that we're going to do our best to make everything work, but there will be some technical challenges in terms of streaming, probably in terms of audio, and maybe connectivity. There may be some delays. This is the thing I had in mind. There may be some delays while we get the camera set up in each section before we start rolling again. So you can just take your cues from us. I'm not going to talk about what simulation looks like. I'm not going to talk about what debriefing generally looks like. And I'm just going to mention that this is like rockin' interprofessional education. This is a picture from our last sim, which was great. It involved Emerge and pediatrics and VOR, anesthesia and ENT. But luckily, as you can see, that's a little patient. Today we have a big patient. And our interprofessional competencies will be rockin' tonight. And just a little comment that although we are all experts in our fields, until we practice together, we're not an expert team, so that's what we're working on today. I'm also not going to talk about crisis resource management. Just as a reminder, that is all of your communication skills and your all of the skills that you bring into play when there's a crisis situation. I'm also not going to use the checklist like I usually do. And you guys in Emerge are probably familiar with this checklist. You probably use it a lot. It's a really great way to just hone those crisis resource management skills. Not that I don't want you to focus on them. I still want that to be really in the back of your mind as you're communicating. But because of time constraints, we're actually not going to use the checklist tonight. So this is how we're all going to look tonight. And here we are. Practice makes perfect. Another sim. Just touching on cognitive aids again. If you have manuals or VHAR resources that you would normally pull up and use, feel free to use them.
Was obstetrical a clue, or?
No, no, that's just a slide I had. Yeah, no obstetrics tonight. You'll also be happy to hear. You can use whatever resources work for you. Just touching on a couple things specific to tonight, I just wanted to remind you about the trauma triad of death. That is when you have a patient with lots of blood loss and they start in this disastrous cascade where they start using up all of their clotting factors and then they start to bleed more and then they produce lactic acid and then the acidosis causes the heart to perform more poorly and that causes increased problems with coagulation and more blood clotting disorders and more blood loss. So this is the cascade that we're trying to prevent or minimize when we're dealing with a major trauma. I thought I'd also pull up a couple slides of the blood product order sets that you might be familiar with. And I am not an expert in this, so correct me if I'm wrong, but typically when you're ordering blood, you need to order the blood or tissue product transport request. But, and again, if I'm wrong, then tell me, but I think in an MHP situation, you actually can just call down to the lab and you don't have to send this request. The second is the order set that initiates the major hemorrhage protocol. So I couldn't fit it all on one page, but just to point out a few things, it's a really great order set because it gives you all of the lab work that you would need. It gives you options to order any of these blood cell products. It reminds you about tranexamic acid if it hasn't been given already. And it gives you some guidelines with respect to coumadin reversal and a reminder about calcium as well. And then the third order set is the major hemorrhage subsequent blood products order set. So again, a nice simple order set, and those are things that you can help get guidance from the hematopathologist on call, who tonight is Dr. Amuni.
Sarah, are we actually putting in orders into a computer? Like, is there a fake patient that's brought up, or are we just saying?
We're not gonna do
okay.
that, yeah.
So we're not
And
actually going through the process of
We could do
ordering?
it in play. We could do it in
It's
play
part of
domain.
play domain,
we haven't
yeah.
set it
Okay,
up, so,
okay.
you can just announce which order set you're going to use, and maybe in communication with Dr. Meunier, you can decide on what products you want at what time. All right. Because we are going through so much stuff, and there are so many steps to this long sim, I'm going to ask you to move through things at a pace that feels a little expedited. So it may feel a little rushed, and I apologize for that, but in order to finish before midnight, I'm hoping that we can do that. So just as a reminder, the rules of sim, it's safe and respectful place. No judgment in anyone's performance because it's a stressful time.
Except for Robbie's, we can all talk about Robbie's performance.
Yeah, we can judge you. Yeah. I do expect everyone to participate as much as you can. There's been no tricks built into the scenario, so it's meant to be a pretty straight up trauma. And confidentiality, it's just respectful to not discuss anyone else's performance. And plus, we're probably gonna run this whole thing again in the fall. So we don't wanna give away any secrets. So a few things that I've already been over. It's gonna be chaotic, like it is with all these bodies and moving parts. So embrace it. This is how it is in real life. If you have any questions about what you're seeing, because the mannequin doesn't make it look so real, feel free to ask us, and we'll tell you what you're supposed to be seeing if it's not apparent to you. I mentioned that we may need to take a bit of a timeout while we get the cameras set up. And just a reminder that everybody has to be really quiet so that, particularly in the two sections, the emerge section and the OR section, where there's people not actually viewing directly what's going on.
So just in terms of seeing
Yeah.
things, the monitor's our friend, is that correct? It'll show you real-time stuff, or do we ask for that?
It will show you real-time things. So as you manage the patient, the vital signs will come up on the screen. Again, technology can be tricky, so apologies if something fails, but we'll do our best.
And if there's something you wanna know, please ask. Something you're used to seeing, and you don't see it, please ask.
In terms of phoning people, and like if I need to speak to Martha or Jane, am I just calling them on my cell phone, or is there a process for SIM that there's like a designated line that they're gonna be?
That's a great question. You'll actually call Dr. Meunier
Okay.
in real life and maybe put her on speakerphone. The other resources like general surgery, orthopedics, anybody else that you might want to call in, maybe just pretend.
Yeah, the unit clerk will help with that.
So we
I
do
will-
have an
I
anyway?
will, yeah,
Okay.
Cheryl's.
Okay.
Just phone through Victoria Locating, that
Yeah.
always works.
So to elaborate on that, then will we be calling like a mock MHP overhead then?
We
if
won't call it
constructed?
overhead, but in the trauma room we
Okay.
can move it.
Yeah, thank you for bringing that up, that's a good point. We're not gonna do any announcements overhead, but if you could say it in a really loud voice. MHP, emerge, MHP, moving to the OR.
We'll get Cheryl to do that. Or anyway, we'll do that.
All right.
Just one note about what you will see streaming here. There is a 30-second delay. So whatever we're doing, you're seeing it 30 seconds later on the live stream.
Okay, thanks.
And Dr. Meunier, if you're watching this, that's probably for you to know as well, that there will be a 30-second delay. Okay. So I'll ask the OR staff to stay here with me. And Emerge and anybody who might find their way to Emerge in a trauma situation.
You want to take care of that?
Yeah. Jessica? Yeah. Summit.
Now we're
I probably shouldn't touch that. You might get a.
Although we don't mind tripping, tripping's okay. He says that someone trips. Sorry about that.
Just have to get the blood.
I was gonna get out of nowhere. People come to me. I'm scrubbing. I never get to scrub. I want to scrub. Of course you're not as scrubby.
I can scrub.
Got it.
And we're not doing that.
No, we are. Well, we are.
Newest for
I got ripped off.
Yeah.
STEM well.
So it's gonna be less.
Bit more,
Okay. How's that?
a tiny bit more. There we go, now I can see.
Yeah, I guess.
Yeah, and the shoulders.
Okay.
Okay.
Starting?
Soon.
It's quite probable that there's gonna be people everywhere, right? So I would probably try to sneak
Is that
in
better?
like this,
Yes,
I reckon. Actually, if I do this instead, I can, do you see the monitor?
from this part, I see the monitor.
Okay, good.
I've got the eyes set to closed and they're blinking a bunch. You guys are saying that that's an error that happens sometimes?
Yep.
Maybe if I make them half closed, they will
If
do
you
that.
close them properly once,
Like manually close them? or push
no,
them?
are they closed?
They're closed on
Okay.
here, yeah, yeah. What if they open? Okay, I'll just do that. Yeah, their GCS is just closed.
Something under repair. Yes.
So when we were building this place, it was all, of course, on paper, right?
Yeah.
And I'd become the CNE, and they showed me a drawing of this room and said, okay, what do you want to put in it?
Oh, what's everything?
This is what we did.
Hey, we got a let's get protective gear on.
first and hooked him up to our monitor as we're getting the story.
Yeah. Okay.
So we're just waiting for sound, so we're just a second. You guys can actually
Put in another
Three. Thank you.
Oh man. Well, I think of this movie and then we're good.
Back. It's good. We're good.
Melissa, you're good? Okay, action. Hey, so this patient is here, so I'm the paramedic that was picked this guy up at the scene. So I don't know if you guys got my report ahead of time, but we found this guy on the highway, highway speed, motorcycle crash. His bike is just destroyed. It's he was about 50 feet away from his bike. His helmet was really wrecked and kind of smashed already. He's got some bleeding from his extremities. He's got this obvious wrist injury and obvious right ankle injury. His blood pressure was dropping on scene. I can try and get you my last set of vitals here in just a second. I think he's pretty healthy. There was no other vehicles in the crash. This was about 15 minutes ago at the scene. Yeah. So his heart rate's about 128. His last blood pressure is 85 on 55. Rest rate about 30. Sats of 91 with our non-rebreather. Yeah.
Perfect.
Questions?
What was his GCS?
Oh, GCS was about an 8. It was about 10 when we first saw him. It's down to an 8.
Thank you.
We gave him an E2 V4 V2 M4. 224. Any other questions? Anything else I can help with?
Any meds on scene?
Not that we saw anything. Nothing in his belongings.
Did you give him any meds?
Oh, we didn't give him anything.
Oh,
No.
thanks.
Sorry.
The
We
rest
just
are-
started the IV access and some normal saline we're letting run wide open for.
Okay, let's just stop the normal saline.
Okay, so I'm gonna start with primary assessment here. And what's his name?
I don't know. Paul.
Okay. Paul, can you hear me? Can you say anything? Can't really do we have an OT spot on there?
That's from 91 when they came in on the
Is it your appeared to be one of the taking his RA right now?
Let's go ahead and call it. We have a hypertensive major trauma patient.
You can touch the set.
What do we hear when we're listening, when we're auscultating?
The big white spot there, that CO2 touch when.
Decreased breath sounds on the left side. You can actually hear.
Decreased breath sounds left side, thank you.
Yeah. What's my glucose? Is that good? The ultrasound, please.
6.4. Let's go to 6.4, didn't we?
6.4, thank you.
Major hemorrhage protocol, ER trauma room. Major hemorrhage protocol, ER trauma room.
Yes, SpO2.
What did you say was your ID? Melissa, what's my temperature? Okay.
Your temperature is 35.6.
Temperature's 35.6.
They've got leads and SpO2 on.
18 and right AC, thank you.
I'll work on a second access. Let's go ahead and get 1 gram of PSA and we'll push that, please. I'll do that.
Oh,
I'm gonna do the IV.
I'll
do
do
it.
Perfect. People are equal bilaterally.
Sorry, pupils equal bilaterally.
Yeah. Pupils are equal bilaterally because no lacerations on the head. Oh, sounds like he's gonna be throwing up. Okay.
Let's get some suction.
We've got.
Oh, it's pain?
We want to do a roll.
Robin, I'm here.
It was fun.
Hey team, let's take the volume down here. There's a lot going on. So we're gonna hand over to Rob as TTL and then I'll help out with procedures.
Sorry, Red, I know you already told me the temp, but can you repeat the temp?
35.4.
35.4.
We're gonna hand over.
Guys, I'm gonna just say it one more time. I need everyone to be really quiet unless you're having an essential conversation. Okay? We're gonna hand over to the TTL. We have a major trauma patient here who's got a low blood pressure, tachycardia, and low oxygen saturations. So priorities right now is we're getting ready to run blood through the rapid transducer. We're handing over to Dr. Tractor as TTL. We're going to go ahead and look for lung sliding given the decreased breath sounds. We've got 2 grams of TXA given. We've got 2 large bore IVs. And we do have X-ray on standby as soon as you're ready.
Have we identified any injuries at this stage? What was the primary survey?
Left decreased breast arm over
Yeah.
left side. Just strong pulses bilaterally, just going through the secondary survey right now.
Okay, thank you. Can you let me know what you find?
Yeah, so we have no subcutaneous after 1 gram TXA. 1 gram TXA, so that TXA number 2 is being given?
That's I already told her. So 1 gram of TXA has been given so far.
Okay,
Yeah.
and there's no going down hospital TXA provided. I think I heard there was no meds given from hospital, correct?
Oh, yeah.
No meds pre-hospital, correct?
If we have the pelvic binder on, so I'll have to check for fluid in the abdomen, but no overt ecchymosis or today.
Okay, I'm checking for lung sliding bilaterally.
Yeah, you'll see it on the ultrasound.
No.
After 89.
Who's getting that?
Sorry, Robin.
Miranda's on meds.
Miranda,
Yeah.
can you draw up kind of right?
There you go, Robin.
Thank you. All right, so once we're done the ultrasound, we might just go through a quick summary and just see where we're up to.
Do we have any sticky notes as to where he's hemorrhaging from, or it's just these bandaged areas? Okay. No obvious abrasions, but he does have an immobilized and splinted left forearm and wrist.
Are there any visible injuries? Okay. Shabs, do you want to ask that question again about injuries so Drew can inform?
Yeah, for sure. So I saw no obvious abrasions.
He's got abrasions kind of everywhere. Yeah, he's got abrasions everywhere, no like active hemorrhage. And then he's got the 2 major orthopedic injuries that are obvious deformities of the left forearm, looks like kind of off to the side, and his foot looks like it's turned 90 degrees.
And sorry, Drew, what was the lower limb injury?
Seems like it might be dislocated. It's for 90 degrees for the ankle, and this guy.
Okay.
Sorry guys, I'm having trouble seeing the vital conditions, so I can keep an eye on the patient's
Yeah, so we're going to get 50 mics of fentanyl for pain relief.
Critical finding, there's free fluid in the abdomen.
Okay, thank you. We'll get the, shall we do the general surgery on the phone, please?
Positive fast, got it.
Relief, 50 mics of fentanyl.
50 makes a pencil, thank you.
Guys,
Now that we know we see the lung again.
Where are you looking?
The lung.
There's your first 2 minutes.
Okay, guys, can we just stop and summarize the findings of the examination and the fast scan, please? So we've got a 30-year-old male, motorbike crash, high speed. Do we have any signs of head injury, Robin?
Should be under the primary signs of
Head injury, GCS? 8, okay. How's the airway looking, Janet?
I'm not hearing a whole lot to this left side.
Okay, anything in the airway?
Do I see anything in the airway? Nope.
And what oxygen do we have him on at the
I'm
moment?
about 100% on the non-rebreathers.
Can we put nasal prongs on as well, please, and if we can crank those? So from there on, we've got what looks like pneumothorax or hemopneumothorax on the left-hand side. Is that correct?
Correct.
And then free fluid in the abdomen, correct?
There we go.
All right, and where are we up to with blood products at the moment?
Unit of pack cells.
All right, can we hang that in, please? Yes, that would be wonderful, thank you. Robin, are you happy to put in a chest tube?
Yeah, I'll do it. Yeah.
Excellent.
That's grabbing here.
So Martha, we've got a 30-something-year-old male high-speed motorbike crash. Hypertensive at the scene, looks like blood pressure is falling. Injuries look like they're essentially located on the trunk, so we've got left-sided hemopneumothorax from the looks of it, and free fluid in the abdomen. Bev, I did notice that the pelvic binder was way too high in the patient, so can we bring that down over the greater trochanter, please?
Yeah, and I'm just thinking with the IBS, so please look at the arm. We don't have like too big to be on this. Chest is just right there. We might look into the
Yeah, if we've got 2 good going IVs at the moment, we'll work with that, and then if we need to get more, we will. So free fluid in the abdomen.
That's going down.
Great, thank you. Robin's going to set up for a chest tube on that left-hand side. We're going to decompress the left chest. Not going to intubate him at the moment. GCS is reported to be 8, no signs of injury. So we're going to
trying to resuscitate for today. He had deformity at the right ankle and the right forearm.
They just set that to go every 2 minutes at the blood pressure, just so you know. Give it that.
Right?
Can we actually run the blood?
No. Through, hold on, through what?
Through this one that goes to the back?
Yeah.
Yep. Yeah, that's right.
Oh, okay.
Guys, we're gonna sneak it right behind you. We have a test tube in. Static. You have a typical test tube, small one.
Yep, that's fine, thank you. And can you guys let me know when the blood's running, please? Janet, can we set up for an airway? We're not going to intubate him at the moment. If we-
Got a number 8 tube ready?
Perfect, and we've got a video laryngoscope. Yes, we can get ketamine and rocks on it, please.
So we've placed a test tube in the fifth intercostal space.
What size is the test tube?
The 20 French.
Thank you.
Can we call for a portable chest X-ray, please?
Right here.
Will they chest and pelvis?
Okay.
Oh,
Let's just keep an eye on that temperature too, you guys. It's quite low. We can try and keep you as
yeah,
calm
that's a good idea. Keep them covered up.
Confirming 110 meters.
So I want you to draw up 200 of ketamine, please, and 200 of rocuronium.
Blood is starting to infuse.
Thank you.
Pressure's down to 79 and 47 with a map of 58.
Yeah, do you want to set up for an airway? Miranda, can you let me know when you're done with those medications, please?
Number 3 or number 4, Lynn?
Should I send that back to lab? Yes, please. No, I do want that. Can you hand it over to is that blood pressure cycling, Bev?
It is every 2 minutes.
Every 2 minutes? All right, so that's a fairly recent blood pressure.
Yeah.
Hi, Rob.
Hey.
Your general surgeon called me.
Yeah. So, a 30-year-old man, has she given you any of the handover?
A little bit. She called up to the OR.
Okay.
Can you just summarize?
So, 30-year-old male, high-speed motorbike crash, has got hemopneumothorax on the left-hand side. We just put in the chest tube. And Shaz was just going to reassess now that we've got that chest tube in. Got free fluid in the abdomen. Pelvic binder was a belt, so we've moved that down. He does have injury to his right ankle that was deformed and left forearm, but I haven't had a chance to assess those at the moment because he's grossly hemodynamically unstable at the moment.
Okay.
Femurs looked okay. I'm not sure about his pelvis at this stage. We're just getting a pelvic and chest X-ray.
Okay, so that's still coming, the x-rays? Can I just get her his name? Okay.
Yeah, that's really long for you.
Okay. I'll grab a sticker.
Oh,
Thank you.
sure.
Oh, thank you.
Miranda, would you please,
Okay, let's look up the.
you may have to call lab. 2 grams of fibrin concentrate and 3 grams of calcium gluconate, please. Yeah, 3 calcium gluconate, 2 grams of fibrin concentrate. Thank you. All right.
Preparing for an airway. Can I get one of the nurses to drop medication?
The binder's doing what it should be doing.
Do you, what do you have?
We have 100 of rock, 200 of rock, and 100 of fentanyl, and 200 of
So,
Hold on.
so there is,
Thank you.
Robin, was there lung sliding on the right?
I would like to confirm, was there lung sliding on the right?
Was there
We didn't
lung
get
sliding
it.
on the
There was
right?
one sliding on the right.
Okay.
After that.
Okay,
Rob,
thank
we
you.
requested a fibrillation, it's on its way.
Thank you.
We're just getting your other medication.
Thank you. So guys, so on X-ray, the chest tube seems to be doing its job on the left-hand side. There's quite a lot of subcutaneous emphysema on the right, but the lung itself doesn't look horrendous. So if there was lung sliding, I'm happy to defer that for now. But once we've secured his airway, we'll probably decompress that if we have time going up to the OR. Otherwise, it might need to be done up there. And it does look like there is pelvic fracture through the SI joint and the iliac crest, but there's no widening, so the binder seems to be doing its job.
think it looks pretty good to me, I don't see too much.
I have a hematopathologist on the phone for you on speakerphone.
Okay.
Just with the MHP.
So how, Robin, how are we doing from an airway point of view?
So, he's making noise. I think it's pain or vomiting noise.
Pain.
Okay. We are just about ready to go.
I've got a number 8 ET.
Sorry, Danielle, I'll be with you in just a second.
You want the calcium?
And 4 blades in your blood flow.
Perfect, thanks. So we are a little soft, so I'm just concerned that on induction we.
So Robin, how would you feel? So he seems to be responding to our blood products at the moment. We've decompressed the left-hand chest. He's unstable, but he's somewhat stably unstable. How would you feel about moving him to the OR? They can induce him up there, secure his airway just before the OR, which I think is probably a safer place when there's a surgeon there that can open his abdomen. Is the OR ready?
The OR is aware and ready.
Martha, how do you feel about that plan?
Could I just take a peek underneath the dressings?
Yeah,
Hi
absolutely.
Nate, I'm Dr. Yo. I see you have some injuries.
Robin, I'm just
come
gonna
in
talk
and
to
look
the
at you.
We
hematologist.
need to just make sure there's no external hemorrhage behind him as well.
Are there any open injuries? Are there
Hi,
any
Danielle,
open
this is Rob
injuries?
Doctor on TCL.
Open.
Oh, and he's squinted?
He's squinted, yeah, he's squinted. This looks.
Yeah, so we've got an MHP running. He's got chest abdo. We don't know about head at this stage. He's had a red cell. He's got some plasma going. He's got TXA. He's getting some calcium and some fib conk is coming. I don't know much about his past medical history at this stage. He's 30, so I would be very surprised. No meds.
Can someone grab his feet,
Guys,
please?
so oxygen's dropping down to 80. So we probably do need to secure his airway down here. So Danielle, I'm going to have to let you go for the moment. Thank you for the call. We do have some preliminaries. We've got pH of 7.2, lactate of 4, calcium of 2, INR 1.4. Fibrinogen 1.5, which we're replacing. Other than that, fairly exciting.
And we'll get ready to sedate. And let's just recycle the blood
Thank
pressure
you.
before we give them any meds.
Can we move this, please?
We can.
If we're going to intubate before, it would be good to be able to see the page. I know. And then his saturations have dropped. So.
Just so everyone knows, we're bagging the patient with a good seal now. Just trying to pre-oxygenate him a little bit. Sounds like we're being forced to act. Does everyone mind if I do a quick airway plan here?
Please do.
Okay. We're going to go ahead and push low dose ketamine because of the hypotension. So we'll stick with 60 milligrams of ketamine and we'll still do 100 of raw.
Guys, can we just be quiet at the moment, please? We're just doing a high-risk procedure. Thank you.
We're going to go ahead. We're going to use the glide. We've got suction ready to go if we need it.
Remain 60
We've got
milligrams.
a bougie on standby and we've got direct as well. There's lots of positions in the room.
Oh,
We need a bit of assistance.
Okay, so ketamine has been given. I think that was
Okay.
a little bit
Well,
premature, but that's
let's go ahead and
okay.
keep eyes on the clock.
That's okay. That's
All
okay.
right. So we'll watch and
So-
just see if our oxygenation happens to improve with their bagging here.
So he hasn't been paralyzed at this stage.
Okay.
Can we cycle the blood pressure, please?
Yes, we do have C-spine collar on, so what I'd like to do is actually take it off and just have someone hold inline stabilization. Does anyone have a free set of hands who knows how to stabilize the neck here? Perfect. So with bagging, the stats aren't particularly high. Oh, they're coming up there. I was gonna say, if he's pretty calm, I could go ahead and even take a look before I paralyze him.
You're happy with that?
Is that? Kind of tell us that. Hopefully lubricated.
How
are we doing? Our blood
When you do the blood
clot?
stuff, we were that's all.
It's got a great,
Do
it's
we
got
have
a
more
great
blood
view
coming?
there, actually, so I'm just gonna go ahead. That's okay. All right.
So it's an MHP, so it should just be coming.
Through the cords.
Okay, so that's a
You
really
can go ahead.
water process. So can we get 4 more units of red cells and 4 units of FFP?
We'll add that to and your fiber is on its way.
Thank you.
Okay. So just over our nose, we're through the cords.
I got the entitle plugged in.
No paralytic has been given. Taking over 2.
Miranda, can you cycle the blood pressure again, please?
Raylene, it's 8.0, 21 at the T.
8.020 FT. 21 FT, thank you.
So while we're waiting, Ms. will you just get a laser of ringers, please? Yeah, okay, if we can just get that running, please. And Miranda, are you free from a drug point of view?
Yes.
Can we get a levo infusion drawn up, please?
Yeah. We're 23 at the teeth now.
23 of the teeth.
All right, once that's secured, Robin, can I get you to repeat the primary survey, just so we know where we're up to? The priority after that, if there is no immediate life threats at that stage, we'll be moving to the OR.
Dr. Cracker, CT is ready for you.
Okay, thank you. I think we're going to go straight to the OR.
You want to go CT on the way?
No, we'll go to the OR. Thank
I
you.
think so.
Okay, hold on.
Thank you.
I believe there are breath sounds bilaterally. We're just gonna re-secure the C-spine here.
So, Martha, I think he's probably going to need something on that right-hand side, but the chest X-ray wasn't too bad. There was lung sliding, but there was a lot of subcutaneous emphysema. But I think the priority is the bleeding, so I think that we should prioritize getting him
Are
upstairs.
we gonna work on getting an OG ready?
I think we can do that upstairs.
Okay.
Thank you.
Just gonna cap the wrap. We just want it primed and ready to go.
I think that we'll start it, please. Yeah, we'll start it.
And what's our working weight, would you say?
Do we have an estimated weight on the patient?
80 kilos.
80 kilos?
80?
Yeah.
80?
Yeah.
Okay. So Rob always had for pre-medication was the 60
Can we
ketamine,
get
so
the
at this
hair
point,
number
he
going
might need
on
something on his way to the OR.
I'll take ketamine with.
Are we going imminently? Because we should start warming him a little bit before we go.
Okay.
So Robin was going to reassess, see if there's anything else we need to address immediately, and then our priority is getting upstairs.
So let's just maybe wrap around a bunch of warm blankets for him for transfer.
All right, so there's nothing else.
We're oxygenating and ventilating him a lot better than before. We're still pretty hypotensive. I think OR is probably the priority.
All right, guys.
Just summarize, I'm Martha, I'm from general surgery.
Yeah, so that's what I was just going to do. So you read my mind. So we've got a 30-year-old male, polytrauma, hemodynamically unstable. At the moment, it appears that our main sources of injury are chest and abdomen, but we haven't excluded head injury. He's had a tension, or he's had a hemopneumothorax on the left-hand side, which has been decompressed with a chest tube, and that seems to be working well. He's got free fluid in his abdomen. Pelvis with the binder on looks pretty good. We've secured his airway in addition to putting the chest tube in, and at this stage he's had a unit of red cells, a unit of plasma with some TXA and some calcium. More blood is on the way, and I think that our next move should be to the OR. Is there anything else that anyone could think of that we should do in the interim before going to the OR?
May I interject? What would you like the neuro to be started at?
If we can just, where does blood pressure go?
Looks like the last one was 81 on 50. Or
81 on 50.
there you go, 85 on 50.
I think we just have it there at the moment, so we don't need to start it at the moment.
I'll just check the infusion chart so we're ready to go.
So this patient has his airway protected, his breathing supported by ventilation with a left chest tube and situ. Circulation-wise, we supported him with only 2 units so far, so we're going to continue the transfusion. He's still tachycardic and hypotensive. Possible sources of blood loss are the left chest, the abdomen. Have we done a log roll to check for any external bleeding?
We have not.
So can we complete a quick log roll and then prepare to transfer?
Just to clarify, what we have for you is active red blood cells that have gone in, and
I
there's 600.
was told we were only giving 2, and there was 4 on the way.
4 has been given.
4 has been given.
And
Okay.
600
Okay, thank
milliliters
you.
of blood out in the chest tube.
Okay.
The fibrinogen complex hasn't been given yet, and then proceed it from
You want to do a
Thank you. I'll
log
hand
roll
it
before
over.
we leave?
Yes.
I got the head,
do we-
we'll need 2 more people.
Okay. Are we, do you want us, when you want to roll, doctor?
Dr. Talbot, the OR is ready for you.
We're great. This way, so let's roll onto his right. Can someone support the chest tube? Okay, everyone ready?
Anything on the log roll?
No. Just remember.
What deformity do I see here and here?
It's like 90 degrees, so it's probably got
Ankle?
yeah, fracture dislocation in the ankle, and then like a wrist.
Sorry guys, I can't see the latest blood pressure cycle from here. What is it? 150, and how's our temperature? 35.
Okay, so that's for transport.
We're just going to do it. I have a
How are we statting now? Good luck.
So at the moment, I'm sorry. Well, yeah.
Hey Rob, just going transfer it. We have fentanyl,
Perfect. All right, what are our barriers to departing with this patient?
The equipment.
The equipment? All right, and how far off do we think we are? Excellent, thank you.
Hey Jeff, let's get the TSA to that.
And, calcium. Work that we're gonna do in the next hour or two is to stop everything. Let's just bring this with us. I'm gonna bring the banner with us. We're gonna communicate
Miranda, would you call the lab and just ask them to work on to bring it into the OR, please? What is beeping at the moment? That's a loud.
We're gonna have to page that we're moving from the.
But everything looks not sure. Okay.
Yes. You want to take this? Yep.
Drew, I'm returning to tell Cheryl that we're moving the MHP to the OR and the fibrinogen will come up there.
Sounds good.
Okay.
All announced?
Yeah.
You're okay to take that there? Yeah.
Are we at a place where we should pause?
There you go.
So, Robin, you can not. You're going anywhere? Yep.
Can I just sneak behind you, Ron?
Of course, yeah.
Thank
Do you want me to
you,
bring this? Is this one of the OR or just the
It is,
regular?
yeah.
Oh, okay, never mind.
Yeah, thank you.
Krista's been updated.
All right.
Thank you.
So
You
we,
can go to the OR and do handover and then meet back in 2050. Miranda, you got
can you
that?
stop the
Go to
patient for a
OR.
second? Can you stop the patient for a second? Can you just slide that on him, please? Thank you, thank you. It just goes across, eh? You got that? Yeah, that's great.
The patient?
Yep, that's great. Thank you, thank you. Thank you for that. Jack, can we pause filming, please? Thank you. Thank you.
You know what I mean? We will take another. Sure. You should go with if you.
Exactly. That'd be some seriously impressive things.
I'm prone to wandering. It's awkward.
This thing hangs out wider than you think too.
It really does, doesn't it? Thank you.
Nope. Let's take this sandwich board off.
Yes, please. Thank you.
So you'll tell us when we can go?
I sure will. Can I give this to you now? Oh no, it's okay. That's fine. Hold on a second, please. Jack, where do you want to be? You want to be down here? No? You want to be down here? You happy where you are? You happy where you are? Okay. Okay. Hold on a second. We're close. Jack, give me the thumb. Jack, give me the Okay, we're good, everybody.
Okay, hi everyone, my name's Rob Tractor, I'm the TTL one. Who have I got in the room at the moment?
I'm the other person, yeah. Celia, I'm a Nancy Durst.
Okay.
I'm the attending Nancy Durst, so you can give me a rundown. You have the old.
My preference would be to hand over to the room while he's still on our stretcher, then we'll get him across and you guys can. So this is Nate. Nate is a 30-year-old gentleman who about an hour ago now was involved in a high-speed motorbike crash, hypotensive on scene with decreased GCS. From the top, there is no external sign of head injury, but GCS was 8 when he came in. We have not cleared his C-spine. He was intubated for airway protection and hypoxia. I'll talk about that in a moment. So he had a left-sided hemopneumothorax compressed with a chest tube that is draining blood. Oxygenation has improved subsequently. He did have subcutaneous emphysema on the left, but the chest X-ray looked okay. He had lung sliding, so we have not addressed the right-hand side at the moment.
So right-hand side is
not decompressed.
Okay.
Abdomen has free fluid on the fast scan. Pelvis looks okay in the binder, but hasn't been assessed without the binder on. He has a left forearm injury and a left ankle deformity, which Dr. Yo is aware of. Sorry, right ankle. So the airway was fairly uneventful. He was induced with 60 milligrams of ketamine that was inadvertently given a little bit earlier. He did not require a paralytic, so he has not been paralyzed at this stage. Other therapies is he's had 4 units of red cells, he's had 4 units of plasma, he's had 2 grams of TXA, he's had 3 grams of calcium gluconate, and fibrinogen concentrate was asked for, but is on its way down from the lab.
Platelet, are you aware?
He has not had platelets at the moment. I have spoken to the hematopathologist. He has not had platelets at the moment, so it's not exactly a balanced transfusion at the moment. Platelets on lab were 118.
118, okay. And are you aware if we do have units on available?
She did not mention, but she's on standby if we need to speak to her. So in summary, mainly looks like thoracic injuries, airway's been protected for oxygenation, and airway protection. Any questions?
No, for now, I'm just kind of worried about that, GCS on presentation, and there's no history of intoxication.
He was quite hypotensive, but certainly could have a TBI, but was too unstable to us as a CT scan.
And Martha, your surgical plan?
So our surgical plan is to start in the abdomen with a laparotomy. Our goal here is to keep the patient warm, controlling hemorrhage, and manage contamination. I anticipate that he will go to the ICU with an open abdomen. Right now, with our chest tube output, I don't anticipate needing to go in the chest, but we're going to brace for that.
Okay, so possibly we may need to isolate a lung, maybe, depending. Yeah. Okay.
I'll hang out for a few minutes just in case you need any help. Please let me know, but I'll stand out of the way.
Yes, I'm gonna grab who will be able to help us with managing the MHP?
The IC nurses.
Okay, thank you. So you guys will hang around and you will, okay, so that will be great, so that's your job. We have, you're helping? No, okay, surgeon stuff. And, okay, alrighty. Who is our circulator?
Shotgun, she's just grabbing some gloves.
Okay. So I think, so we only have 2 peripherals. After he's transferred, I like to put in an art line and see IJ. Before we start. We're just taking all the shorts. Oh, yeah, just 3, 1, 2, 3. Down, 1, 2, 3. You going all the way or onto the board? What do you prefer? Let's maybe go onto the board and then. Sure. Okay, 1, 2, 3. Over to the bed, 1, 2, 3.
He doesn't have a Foley at this stage.
Okay, we need to put in a Foley. You want to hold out? You want to go forward? We don't want to keep on. Okay. No Foley come towards me? No.
Okay,
One,
we need to keep this
I see
Go ahead, Trent. Thanks.
Alright, so let's just get them up the bed.
I would do that.
When someone grab the sheet here, he's on that, they want to move them on. 100% do, because it's happening.
Wow.
Wow.
Okay, cool. Can we just reassess his vitals here once he's moved? So pretty stable still. So maybe I'd like you to start on the. Yes, I'm just gonna talk about our sheets. Okay, so you're doing central line. Janet, can you do an line? Okay. So we have it ready. We have it ready. Okay. intubated. Okay, so he's gonna need an anesthetic and probably more. Yeah. All right. Janet, I see Janet, hi. I just want to confirm and make sure he is inactivated, so that means we can keep getting products.
You have to tell me what you want to do.
Okay.
So I go in, so we, he's had 4 units, but 2
Yes.
units of plasma. If you want more,
Can we get labs? Okay. Okay, and the initial blood work is before the transfusion?
Yes. Yeah.
Okay.
So the lab.
Is he, so if we can get your lab to get us that, Janik is putting in an art line, so perfect, we can take a sample and we should.
So they actually did draw labs downstairs and they've just come back.
Alright.
White count is 12, hemoglobin is 55.
55.
Platelets are 30.
Yeah. More red stuff.
Platelets are 30.
30, yes.
Chemistry is unremarkable, creatinine is slightly high at 180. Calcium 1.3. Blood gases, pH is 7.16. PCO2 38. CO2 130.
Okay.
Bicarb 17, lactate 5.
Okay, alright.
Coags are elevated, INR 4, NTT 80, fibrinogen 0.8.
Okay, so we, okay. So to summarize, we are in kind of acidotic, coagulopathic state, probably heading that way. So at this time, I am going to,
We've just done the 5th unit of blood.
Perfect, so we're gonna have to give as many units that can come.
Okay.
We're gonna need an adult dose platelet. Do you think you can do that, or should I call another pathologist? If you can do that, that'd be great. So that's taken care of. I would, in the meantime, I would also give Rayner's lactate for fluid resuscitation to, let's get to a map of, oh gosh, probably 65 will be good. Too high, then he bleeds more. I would, at this time, also increase his ventilation if we can to help out with the acidosis. And Kaylee is putting in central line. We have access. Okay. And we've increased the room temp. Let's put this bear hugger on.
I've got some paralytic if you want me to.
Okay.
Just go this.
All right. So while we resuscitate, I think we probably should start to. Yeah, we probably should start to just kind of get the bleeding under control. So, okay. All right. I am going to.
Okay, we're gonna go for our
Plasma is infusing. Okay, thanks. So
both arm gels, we're gonna
Wait,
the drugs and everything.
Yeah, okay for now.
Oh, sorry.
Who is ICU on tonight?
I think it's Mark James.
Oh, Mark.
So I'm gonna put pictures.
I was gonna see if he wants to come here.
Can we put this up here?
No, down now.
So I'm gonna lower then. That's
Dr. James.
Unfortunately, you're tied up in ICU.
Oh, darn. Well, I'll let you know, Mark, if things go sideways, but just wanted to see if you have any advice to offer in this situation. We're just kind of aggressively resuscitating rather than damage control.
Sure. I think we probably dealt with all of the bits and pieces, massive transfusion requirements,
Yeah.
and probably instead and use a high cap line. Use a cordless as opposed to triple lumen just for the volume. Short line, great big lumen.
Yes. Okay, so where's Martha? I just pretend we have a cordless here. Yeah? Okay. Is she gonna pretend to? Do you want me to like open it?
And just a question, Karen, how tense is that belly? How tense is the belly? Because you may lose the compartment.
How
It's
tense?
so tense.
It's so tense, we will lose the compartment.
So I need good. Make sure your pressure in line.
How
Suggest
are
that-
you with cross clamping behavior?
Unit 5 has gone in as well.
Thank you. Okay, so let's, okay, so Martha, before we start, I just want to get the pressure pressures going, so we have some wiggle room. 5, and I am giving a lot of fluids through this other line. And our temperature right now is 35.0. So, okay, so let's get the air hazard line.
This is gonna be a challenge.
Okay.
Are we okay? Mark along?
Just prepping.
I did prep.
Okay. So if we have platelets, can we give
Instead of this, or do you want to
Yeah, okay, got the platelets.
Okay,
so let's also been given paralytics. Okay, let's chase with some lactated ringers as well. Yeah. Yeah.
Sorry guys, I'm gonna have to do this.
We're gonna trickle it in.
An Omni?
Can I get an Omni, please?
Omni? Sure.
Mama, you can just.
We can pretend we open an Omni. We're gonna
Okay.
put an Omni on.
Just please? Yeah.
We're gonna set up 2 judgments and we're gonna need 2 potteries. Can we cycle the blood pressure again?
Okay.
Can I get another section?
Here.
Karen, did you get that art line in?
Yes, it is. Yeah. It's been in like a minute.
Yes.
Alrighty, so everybody start.
And can we also get the pottery? Okay.
Yeah, I've got the pottery. Pottery is sorry, I just can't see the chest.
Still waiting on a second section.
Yes, the chest tube is on the side. Okay, I'm just gonna do this like this. You got that? Yeah, alright. So why don't we start some pressures? Okay.
We started our epi downstairs.
Oh, perfect, thank you. And our Foley is kind of bloody, and our chest tube is. Our chest tube is bubbling. Is it whatever? Chest tube is.
Just you, that is working great.
Okay, all right.
Yes.
Your ringers is running.
There, could you plug that in for us?
Yeah, thank you.
Yeah.
Oh, plugged in.
Yes.
Okay, alrighty. So we are resuscitating, the blood pressure is going, our vitals are holding, so I think we should carry on. Okay, good. We're going to do a trial laparoscopy.
You can ask for your people too.
We're going to.
Patient's name?
So this is Navy River trauma laparoscopy, topical thoracotomy. We've got 2 sections, 2 potteries. We've got lots of tasks. We're preparing to control bleeding and contamination. Our goal is to keep him warm and resuscitated throughout the procedure. If he decompensates from a respiratory point of view, we'll put in a right-sided chest tube. So far, our left-sided chest tube has had minimal output since insertion, so our suspicion for a traumatic chest injury is low. And were we good to start?
Yeah. Antibodies on, pottery 30 he's on Meguranta, 2 potteries on.
Antibiotics in?
Antibiotics are in.
2 grams of Anta, yes.
Haley, what's the airway pressure like? Okay, so we're gonna make a laparotomy incision.
Airway pressure.
35. And now we're gonna open the fascia with her.
Yeah. She wants to just.
Okay, so we've got, did you want me to draw some here or anything? Or vaso?
Yeah.
Good.
I think you're gonna actively evacuate blood and plasma. Alright, so we're gonna start going here.
I think we should pressurize everything and just give it time. They're bleeding times here, so.
I'll put the ringers in the rapid infuser.
And then we also have a cordis now, so we can give blood back.
This is the abdomen part.
Yeah. Okay, Karen, we have a lot of bleeding and evacuated a significant amount of blood. We have the full abdomen now, so we can give you a moment to count. Okay, thank you.
Okay.
So.
We're just going to rapid
Okay,
infuser.
great. And BP, is that up to date?
It's coming, you call anyone to call, Dr. Moon.
Where's our R line?
I can't get those.
You need us to someone to do that?
Sure.
Jess is right here for you.
Oh, Jess is right here.
Yes, I am. What do you need?
Would you be able to call Dr. Mounier, hematopathology, to to update her about our situation?
Yeah. The number is over there. I gave it to Kitty. Kitty, the number that I gave you. The paper?
Yes.
There's it.
I have very little space over here. Give me 1 second.
No, I think I have here.
Okay.
It's not a big paper.
Okay, bye. No, that's not this.
No.
Okay, we're gonna start slowly unpacking the abdomen to look for the source of bleeding.
Our vitals are still decent, except he is still cold. Everything's 4-7. Can you put like warm things in there or something?
I found it. It's right here.
Like just put extra warm things.
Some warm things.
Oh, hi there, Dr. McGay. It's Sarah Wall calling. I'm the anesthesiologist on tonight, and we have a situation with the trauma patient in our SIM OR. And this patient has ongoing active bleeding, and we're in a massive transfusion situation. So far, we have given, how much did we get?
6 units of blood, 1 unit platelets.
I have a lot of whatever.
I thought 4 plasmas. No fibrinogen. I think
We're waiting for it to come.
we're waiting for it to come. How many? Do you know how many units, Janet?
No, I don't.
This was
I think you're up to 6 units.
No, how much fibrinogen? No fibrinogen.
Yes. Okay. Okay, thank you. Okay. Yeah. Yeah. Okay, great, thank you. Anything else? I think we'll just carry on with that for now, and we'll let you know if anything changes. Thank you. Bye. Okay, so. Are we continuing to collect ringers in the meantime? We need 2 ringers, and we need the plasma when they come up, the fibrinogen, and more blood. And, did we get the lab come while we were in the OR at all?
Not yet. Do you want to call it out?
Yeah, please.
They should come.
They should go to mine.
Yeah, they'll come.
With the MHP.
Okay.
So we can't get the.
And our vitals,
They were looking good before. They're just
So
running
should we
out.
call them?
So we cannot get the art line.
She's got her.
I can't.
so Martha, what are your plans here?
So once you're happy, we're gonna start taking our packs up to try to
You've been
identify
downstairs.
the source of bleeding.
Okay.
Pressure's looking good. Just with our vaso running, I've got other pressure should we need them right here. Go.
Start to look at the pelvis.
This is looking good,
Very
but
small.
as you explore the rest of the abdomen, you notice that there's a large splenic laceration. Looks like that spleen is going to need to be removed. It also would appear that there's a small bowel injury.
So as we've taken our packs out, we've identified a splenic laceration and a small bowel injury. So what we're going to do now is a splenectomy. So for that, we're going to need retraction.
Dr. Wong,
We're
for
going to need vertical ties, large clamp.
She said to get 4 grams.
Yes, so we need 4.
That's it.
Yeah,
Okay.
we have
I need
Okay.
800 GIA 75 Lula stapler to and the
The other side. Like the other side.
Yeah.
And I
So
think
we're gonna
like
mobilize
that's
the
our
spleen,
so
identify
high.
the splenic hilum, isolate the splenic vessels, clamp them, cut them,
But you're still
biopsy the
Yes.
splenic vessels. Okay, we'll do packs and leave left upper quadrant. For a small bowel injury, we're just gonna perform a small bowel resection, isolating the portion of injury and taking them as comparing and taking them into continuity. At this point, we're going to irrigate the abdomen, assess for any other injuries, leave packs, and then we'll plan to place it back with the temporary abdominal closure. We'll just keep releasing it.
How's our blood pressure doing with all this manipulation?
Fibrinogen is infusing.
Thank you. Do we have labs back yet?
No, the lab has just come, so we'll be back in 15 minutes.
You guys, if you think it's the patient's stable, I have splinting stuff and X-fix stuff, but if you don't think, then they can go like this. They're not major injuries.
That's for real, I don't know.
You don't actually.
That's
the
exact. Does he have an open fracture?
She said they
that
thought.
you know?
She said they have a fracture, just a deformity at the ankle and the wrist, that's splinted, so I can always do it.
Yeah.
later.
Okay,
Yeah.
2, 4.
Perfect. Not stable, not stable.
Fibrinogen.
Not for.
Okay, thank you.
No, silk.
His heart rate is
Silk.
Okay. His pulse has been steadily increasing.
Okay.
We're just repeating the blood pressure now.
Yeah.
Okay.
All that mental
Good,
break.
right?
Yeah.
Now his stats dropping too.
And yeah, his stat is dropping.
Ooh, what's our chest tube looking like?
I'm just gonna take a listen.
Huh?
Chest tube on the left looks good.
Okay,
I'm just taking a listen to his chest right now.
What's the right side like? Is it expanding?
You know what, it almost looks like your trachea is deviating.
My trachea is deviated.
I'm not feeling much.
Your airway pressure has increased.
Okay, okay, so we have a tension pneumo probably on the right side. So Martha is already working on it. Are you gonna put in the chest tube for me? Okay, so can we get,
Here's some chest tube stuff.
get a bronchoscope as well? Yeah, probably the other bronchoscope. So we may have to do main stem intubation for the time being.
Dr. Wong.
Okay,
on
nice.
his 17th, his letter just had no calcium.
He said, no, I thought he had
No,
calcium.
downstairs he did, but.
Okay,
he's at
can we please give him the 1 gram to start? Thank you.
So nice. Right here. Oh, what is it?
Can we get a Y for this girl back?
Thank you, all right, chest tube. We have a right chest tube, and is it breathing?
Okay, so we have the bronch coming.
Cells are coming out.
Cells are coming up? Yay, okay. Sorry, Shadna, I should just told you I just needed the actual camera, like the actual bronch, but that's okay. It's fine, just stop. It's okay.
How's his blood pressure is really low and his heart rate is way high.
Blood pressure's coming out.
Okay, what does our art line say for the blood pressure?
Our line says 78/45.
Okay, but his heart rate's still 154. We've got.
Our rate's coming down after the chest.
It's coming down into the chest tube. Okay.
And the gram of calcium has gone in.
Okay.
So that's gonna help. Are we seeing a lot of blood coming out the right side as well from that chest
it was
tube?
just a large gush of air.
Okay, cool. Okay.
Surgically, we decompress both sides of the chest,
Sure.
we remove the spleen, we cap it, we don't see any ongoing major bleeding.
That's cool.
Okay.
Our heart rate's better.
We're gonna put in our back to keep it warm.
I have a shield.
She's
That one is.
Dr. Wong? I'm just gonna splint him while you guys.
This gentleman. Cycle, I think, was from posture. Tachycardia, GCS 8. Major thoracoabdominal injuries. Also some orthopedic peripheral injuries that are just left right. So he's had, now he has bilateral chest tubes. We're actually ventilating. Actually, he's pneumo on the left and pneumo on the right. That he had significant splenic lacerations, so Martha has already completed splenectomy, and the small bowel resection just did that like we
Hemostasis done?
Hemostasis is adequate for bowels in discontinuity.
Discontinued, very open.
Belly is open, we place the back pressure. There's some packs left in that.
The C-spine is not clear, you can see the collar still there. We have been trying to treat the coagulopathy, the acidosis, the also hypothermia. Yeah, so we're kind of not winning with the temperature here, 34.5, despite our efforts. We are waiting for a new set of labs with resuscitation and surgery to see where we're at. But he's had now how much of products?
8 units of red blood cells, 1 unit of plasma, 1 unit of platelets, 4 grams of fibrinogen, and 1 gram of calcium.
I think in a rich peritoneum, the pelvis is fine.
So the pelvis is stable, there's no zone 1, 2, or 3, retroperitoneal hematoma, there's just some spleen in the small bowel.
Long bones are intact.
Long bones.
That's
No,
clinically,
no
not
open
imaging,
injury,
but
and
clinically.
I've re-splinted them. Are they going for imaging? Can you have them on? When you
So
go?
what are the next steps for this fellow? What imaging is head?
I mean, ideally, we're gonna do a CT head, chest, well, CT head, neck, chest, abdomen, pelvis, CTA neck, and then X-ray the long bones.
Okay.
Yeah. If they're going to the CT, can you just add the wrist and the ankle in there?
So stable,
Yeah.
stable shot.
Yeah.
Sure.
So at this point, we've got hemostasis in the abdomen, valves in discontinuity, we will need a probe, but pull the catheter, and the time will be the brain back, to compensate for release physiology.
I think the challenge will be keeping him warm.
Yeah,
Transport.
for sure.
Like he's already 34.5.
And we've had a bear hug around.
Anything like that makes me feel that probably in the ICU, just give some DDAVP for exercise tissue.
Okay.
30 months.
Yeah, okay.
20
What's that
months.
TXA as well, so
Yeah.
yeah.
Is that TXA 2 grams?
2 grams.
Okay, so I think that's it, running arm drops.
Yes, we've got something with that. Just a little. That we haven't had to give any anti-invasive, but we've got it.
Ongoing volume resuscitation, big issue,
Yeah.
hypothermia, and bleeding. Big issues, and then our diagnostics. We'll make a plan for the spot in ICU. I'll make a call to the folks downstairs, and we'll make it happen. We have a accompaniment to the X-ray department. Okay.
Come down.
Yeah.
Yeah, I'm gonna call.
Perfect, we will talk to them.
Okay.
And I'll call the folks in ICU to make
Okay,
it
great, thank you.
Okay. Pardon?
He'll need a tetanus shot, he said 2 grams of that.
Sure.
He's going to disconnect him from the ringer. We want it in Yeah. We don't have any sedation.
So,
He was paralyzed, yes.
okay, so you'll need some-
I'm going to reparalyze him now that the surgery's done, so he's going to get another 15 raw. We have not, we've been running SIBO, but we don't have any sedation.
Yeah, so we need something.
Okay.
He's
an ass.
My dad's a protocol.
So the SIBO
Yeah, and then we can do extra when we're downstairs.
When we're downstairs, okay.
I'll check with the ICU.
Okay, perfect. We'll see you
Are you okay
downstairs.
to-
Yes, I
I'll
will.
take it down. Okay.
You need some nurses to go with you? Yeah, we'll see.
I see nurses are going downstairs to bring the stuff.
Oh, okay.
Well, we can
help.
Well, we can help with
Okay.
Go down with the patient, or do you want Karen?
So, right,
Because you're
yes,
Yeah, okay.
Oh, it's been a really good help.
And we're gonna have to do the overhead page to say moving major hemorrhage protocol patient from OR8 to civilian.
Okay.
So that's from the lab people and the.
Nowhere to go.
Blood product.
Just go to the, I'll talk to the ICU about DDA.
Okay, great, thank you.
I'll see you downstairs.
Thank you.
Sure.
Okay, I'm gonna, is there an option? Oh, wow.
Yes, let me make sure.
It is.
It's very empty.
It's very empty.
Full now.
It's full now. I just grabbed a new one.
Okay, perfect, thank you. So, Janet, can I pass this to you? And then once we move the bed, we can get the airway switched over. Oh, and we need to bring this with us
Okay, Colby. I haven't watched the fights.
You also have a second test tube.
Can I see my final score on this thing? After vitals.
Is that the actual test that I will pretend?
Yeah.
Yes. Easy.
Next 10. Can you, yes, please, thank you.
Are we in the break? Are we in break?
All good?
Turn on three.
All good? All the way over, 1, 2, 3, thanks, you guys gotta make sure that.
Make sure the tubes are coming.
Alright, gentlemen, everybody's ready? 1, 2, 3. Yay, done. Okay, so if you want to get that hooked up, I will hold on to this. We're still ventilating. Takes on down on yours. Okay, can we unlock the bed and move it out so that we can get access to the gas tank here? Yeah. Thank you. I will put this in.
Put our little sign on him again.
Yeah.
Can we put this sandwich board on top? Oh,
Yes.
How do we do it?
It just goes literally on top of this.
Literally on top of it.
Okay.
Rumor CT.
Great, okay. Oh, I need my pressure. Okay, so if you can manage airway, I'll watch. We're not crushing you, we don't want to crush you. Okay.
Pretty hard to crush me.
I went and looked in the other room and it was looking great, by the way. Yep.
Was it?
Yep, yeah, it looked just perfectly chaotic, but it was good, good visual. Yep,
Communication?
yep, yep. The sound went out a couple little times, but it was mostly all there.
Awesome. Sound doesn't probably have this.
Yeah, like, are we all trapped? That way, okay. Off of there, okay. Sorry. Did I see my vent up there?
No, you didn't. I think.
So we have for IV access.
So we have Cordis, we have 2 peripheral IVs, and that is it. They're locked.
you go here, I'm gonna go watch
You
the
do inlet
sequence.
stabilization, and I will.
All the way.
1, 2, 3. Go to Kim off.
When we leave the board off.
Okay, so that it's easier next time.
Okay, now we'll just move the stretcher over this way.
Do you want me to just do that while you get set up? Okay. Okay.
Oh,
Exactly.
So
Okay. This can now go. Thank you guys. What were you got ventilating?
Thank you.
Pretty tall guy, so.
Yeah.
So we'll move over to there, we're gonna say
One medication isolation, yes.
Oh, switch for what?
calls back, and everything else.
This is the best. I'm on you.
You know, we can afford to do work. We're no longer You have a ranger ready in case we need to use it.
Rob, somewhere?
Pass the chest tube through the other side.
Would you like to clarify exactly what studies are doing?
Okay. So we're going to start with a non-enhanced head CT that's fine. Do arterial phase, circle Willis, CTA in the neck, arterial phase bottom of the pelvis, and then a venous phase abdomen and pelvis. Okay. Iron hole. Am I actually going to run this or no? So that's it? Or?
I think so. I think Dr. Yeo wanted an ankle too.
Okay.
And a wrist.
And a wrist.
And a wrist.
Yes, ankle and a wrist if you want.
Sure.
I'm not actually imaging.
No. No.
It's more fun.
Okay. So.
Yeah.
Back
over?
Yeah.
I'm gonna go with Mama Vic.
Oh, you're gonna go, yeah, I got my transport vent, so I'll be able to.
Transferring back?
I'll leave them on board or we take them off?
So I'm just wondering if you've noticed any changes in
He's become a lot more tachycardic and a lot more hypotensive.
Dr. G.
Where's our?
Dr. James? Mark?
Mark J?
Mark J.
Dr. James?
Feed the doc in here,
We've got a tachycardia and hypotension that just developed.
Okay.
I
Let's
also
feel for
do.
pulse. Good.
Good. Pulse? Center pulse?
Is there a pulse? Center pulse? Very weak.
Presses are yeah, please. Yeah.
He's got cyanosis as well. His SAT is 84%.
Sure.
Okay, got a rash.
Look at that.
Oh, we're having, I think, probably an anaphylactic reaction.
Yeah. This would,
Is that
yeah.
contrast still running?
Yeah, so stop the contrast, please. Do we have one of those memory aids handy, or should we run to the operator and get one
I
for the
have some epinephrine here if you want to make some
Yes.
epinephrine.
Right.
Okay,
And then we give steroids as well.
so I'm gonna, what do you want me to give for
Maybe
epinephrine?
first.
Okay, gravity diffusers.
Yes, okay.
Not that pump. I am happy, not push.
If we have it, do we have it? I only have push epi.
So for anaphylaxis, we want to give
0.25
We can also in the OR give IV epi, but if you have
Sure.
IM,
Does anyone
then.
want to call a code blue?
Yeah. Okay.
So I will
Call
run and
code.
go grab some
So we-
IM epi.
Okay, I'm gonna start just giving IV
ahead.
epi in
Go
small
ahead.
doses.
We'll call the code blue overhead,
Yeah, call a
please.
code blue.
Okay.
I've called the
And-
code blue.
And so that'll get additional ICU staff here. And, correct. And we'll get the code card in the room,
Get
please.
the crash guys. Someone get the
Somebody tell us where the crash card is?
Yeah.
Okay,
If you could-
so we're gonna give 0.5 IM epi. Right here.
Done?
I've got my oxygen at 100%.
Mark, I've come back. I can help with anything you need me to.
Sure. So the presumptive diagnosis now is, in addition to hemorrhagic shock, he now has a rash,
Oh.
significant hypotension.
And so you just give an IM.
Initial doses being given. Finding him pressures are re- Grant is, sorry, 1 to start. Yeah, 100 milligrams to start.
Okay. Okay. Happy cortisol next.
Okay. Go for pulses.
How much of hydrocortisone was that?
100.
100.
Pressures are getting slightly better, heart rate tempting.
But
FRT is still 1. That's coming up. Slowly. Ventilator pressures
improving.
improving. Okay. Pause for a moment.
Slightly better.
Yeah. Volume is running.
Volume is right.
Yes.
And no ongoing hemorrhage. Make sure there's nothing.
Yeah, there's nothing additional.
The chest tube is bubbling. Is that correct?
That is correct.
There's no-
They're
no
both
troubles with
working
the
well.
chest tube. Okay.
Okay.
Same that side. Okay.
Yeah, both chest tubes.
Anything else to suggest? Well,
I don't think so. It sounds like everything's
we covered all those bases.
Done any,
So we got, if we could add data into the mix, if his pressures were high and it remains, his venting pressures were high and it remains hypoxemic, that's what we can give it a whirl. Right, for now, it's right up the storm, I think. But we don't move the equally, well, it's improving quite nicely actually. So sensor on hemodynamics of markedly improved. And we can probably contemplate moving now at this point. We have a window of opportunity down to the ICU, just looking down the hallway. Is everyone comfy with that?
Yep.
Okay.
So we're gonna transfer? We're gonna transfer?
Pardon?
We're gonna transfer.
We're going to transfer and then take it to the
Dr.
ICU.
Johnson is here and he can give you a summary of the preliminary findings.
Sure.
Okay, on the CT head, there is a comminuted fracture of the right calvarium. The fracture lines extend through the right frontal sinus, right superior, inferior, and lateral orbital rims, zygoma, and right skull base. The fracture also involves the right TM joint and right external auditory canal. There is extensive right frontal parietal subdural hematoma. There is mass effect causing leftward midline shift by 1 centimeter, and the right lateral ventricle is compressed.
Ask you to pull the neurosurgeon.
Numerous intracranial locules of air representing pneumocephalus, large superficial right-sided hematoma, and periorbital edema. Hemorrhagic product fills the paranasal sinuses. Into the chest, the aortic arch, conventional arch anatomy with no stenosis of the great vessel origins. The carotid arteries, there is no dissection or stenosis. The left vertebral artery is dominant, no vertebral artery stenosis or dissection. Intracranial vascular. The cerebral arteries, no intracranial stenosis. The intracranial vessel, no intracranial stenosis, intracranial vessel occlusion, dissection, aneurysm, or pseudoaneurysm identified. The cerebral veins and sinuses are patent. In the neck, the cervical spine is anatomically aligned and the vertebral body heights are well maintained. No vertebral compression or vertebral fracture. In the chest, the endotracheal tube is in good position. Bilateral chest tubes are in satisfactory position. A small left residual hemothorax. The right lung is well aerated without pneumothorax. Heart and great vessels. There is no pericardial effusion. Right-sided internal jugular vein venous catheter is in appropriate position in the right atrium. No abnormality in the hyla or mediastinum. In the chest wall, there are left-sided rib fractures involving the 1st through 6th ribs and the 10th rib. In the abdomen and pelvis, the patient has an open abdomen from a recent laparotomy with a vac dressing in place. There is packing surrounding the liver. There is a grade 3 hepatic laceration with no active extravasation. The patient has had a splenectomy. The pancreas is normal. The kidneys appear normal. A Foley catheter is in situ. There is an acute repair of a presumed small bowel rupture. The vascular structures in the abdomen, there are no acute abnormalities. In the mesentery and retroperitoneum and peritoneum, there's a small volume of high-density fluid in the pelvis, presumably a hemoperitoneum. The abdominal wall, no abnormalities identified aside from the laparotomy. Bones, bilateral L1, left L2, and left L3 transverse process fractures. So final summary, significant right-sided calvarial, bilateral facial and skull base fractures associated with a large subdural hematoma, as well as pneumocephalus, causing mass effect with leftward midline shift and right ventricular compression. Bilateral chest tubes and left-sided hemothorax, laparotomy with splenectomy and a grade 3 liver laceration and packing in place. A small volume of residual hemoperitoneum. Left-sided rib fractures and lumbar transverse process fractures.
No comment on the pelvis?
Sorry?
No comment on the pelvis?
Nope, okay. On the pelvis.
And not very reasonable.
Yeah, they did not comment.
No comment. Okay.
Our next set of lab values will also come back.
Sure.
So, white blood cells 15, hemoglobin's now 80, platelets 35, potassium 2.9, glucose 6.3, creatinine 200, chloride 110, calcium 1, magnesium 1.3.
Sure.
That's me.
2 grams of calcium per week. And then have we spoken with hematologist for some more platelets, or should platelets again? Have we received platelets? Because platelets are now 30.
Yeah.
We'll need another adult dose.
1 unit of platelets has given.
We'll need a second adult dose.
Okay.
We'll place that order.
Okay.
Mark, I'll give neurosurgery a call. You have it. Yeah, you have it taken to ICU. We'll await transport, and I'll arrange that.
Yeah. Okay. So for for the ICU nurses who are going to be coming us to the ICU and then the RT, minimize the peak, please.
Keep down.
We draw the pressures up a wee bit. Prevent secondary valve injury. Increase cerebral diffusion pressures. Aim for somewhere around 70 if we can. The hemorrhage is now controlled. 70 to 80. The hemorrhage is now controlled. And we'll deal with the fallout should continue. Keep steroids on the wings. Keep epi on the wings for now. And we'll have some more epi running. Once the platelets are here, we'll do TDABP. Medical hospital pharmacist.
We'll call the hospital, the pharmacist on call.
Yeah.
Okay, we'll go to the switchboard.
30 miles.
Yeah.
Which is 100 kilos. Simple. Okay. And we'll all allow C-collar in situ spinal and spinal portions please for the movement. Okay.
Just need to get a save.
How is that?
Wrist.
Yeah, you should turn up the rates. Yep, rate up. I'm gonna put the rate up and turn the volume down, I think. Yeah, I think that's a good idea.
So, Mark, I've spoken to neurosurgery and PTN. They're arranging transfer as soon as they can.
And then making a comment on medical
Yeah, all of those things. Secondary prevention is taken care of.
Perfect, we'll take care of that. Okay, so let's, I'll help with the movement and accompany him down the hallway.
Yeah.
Stay strong. So, Denise will look at the wall.
Are we ready? Are we just gonna stay on the board?
We're
We're gonna stay on the board.
You just grab the, very good.
We're going all the way on that way?
Stand on the bottom. Thank you very much. Okay.
Awesome running around.
Continuity of ICU staff, or do we have a new conversation?
That's still, I think. Where are the ICU nurses?
You've all been involved with this process. Okay. So the synopsis is, as best I understand it, high-speed motivated accident. He was a motorcyclist. Hypotensive on scene, presented to the emergency department with hemorrhagic shock, with a closed head injury. Went into the operating room, massive transfusion initiated as part of the resuscitated plan to the operating room for damage control, laparotomy, splenectomy, and then subsequent trip to the radiology suite with open belly, small bowel resection with bowel in discontinuity, so packed and has a back dressing in place. Additional findings at radiology, come back to the heads, but stay with the belly. Go a grade 3 liver lac, spleen packed off, no hemorrhage currently, and a small intra or pelvic hematoma identified. Bony injuries that have not been explored, is that correct? They haven't been explored yet? No, we haven't done the additional imaging of the extremities. Good, don't need that for now. We're not going to delay transfer to get those done. Then the head is the more troublesome pathology that requires with a bear hugger. His head injury is such that he has a massive subdural or large subdural with mass effect, and requires craniotomy, craniectomy for drainage emergently. We're managing it conservatively currently, warming up as best we can, driving up the pressure, and hyperventilating him a little bit. Mannitol being given, we'll give him mannitol at 1/4 gram per kilo as a bolus. We'll elevate the head of the bed just a wee bit, but not like so, but just as a trindelabit. We'll keep him spine. We'll do the trindelabit. Function by giving him some desmopressin. Hasn't needed any nebulized salbutamol. And that's it. Anything I've missed?
You want
All good with that?
Just noticing that his vitals are changing.
Thank you. Oh, there we go. Pressures are getting a little better. Who's a good surgeon who would like to do a craniotomy?
Can you get me on the line?
And speak and get a brace in bed
That's
for
They're
at least
in
Burholtz.
the OR, they're gonna be about half an hour.
Oh, good.
Okay, so
Okay, but, okay, they can just talk me through it, because
Sure.
that happens.
So,
Yeah.
okay, so
No.
thank
Said
you.
no.
I think that cap now is that we've done all the conservative therapies. We don't have a means of stopping the bleeding, and so now we have to drain the hemorrhage. And a bold surgeon is what it takes.
Yes.
And you get bold surgeons and old surgeons just think
Just
it's all
listen to
bold.
what they say on the
There we go.
phone.
And so I'd implore the surgeon to come and cut some holes and drill some holes. Yeah, and that reason why I asked. I don't know where to take it from. So I have this patient, so when you were involved in the operating room, he now has a significant subdural response and herniation. He'll need something. We start about doing that in the operating room, or here if we actually have to, because he's probably too unstable to move.
Okay, well, if he's too unstable to move, we'll find a surgeon who
background
Okay, we'll get
as
some.
a
Are you okay to do it here? Do you want
Absolutely.
an anesthesiologist here?
I'm okay.
Okay.
I'll manage the anesthesia side of the house.
Extra.
5 mics per kilo per minute.
Okay, we're gonna pretend.
Oh, sorry,
We're
yeah,
gonna
mics
bring down
per
the
kilo per-
verbal
yeah,
case
mics per kilo per
card.
minute.
Yeah, we'll hang a
When
bottle
you
of propofol
And
on our.
Take this one.
Okay, Shamlam's brought down the Burhold case card and some prep stuff.
and we'll paralyze him
And we're gonna
with
paralyze-
give him 100 of rock.
100 of rock, we'll go to.
Can I get the razor?
Okay, we're gonna get 100 of rock.
His eyes have been opening the whole time. It's actually been creeping me up. I keep paralyzing him and he's
Mannitol is
We're just
worked
intervening.
its magic,
Yeah, okay.
maybe, or he's having a hallucination.
The 3% saline is in.
He's not having a seizure,
Yeah.
maybe. So why don't you get some, give me some midazolam, please, a couple of milligrams of midazolam.
He's not seizing that eye.
It's been doing that the whole time.
Yeah, that's it.
I paralyzed him like 30 times.
Okay, so no seizure.
I tried.
Dave, have I
Pause
blurred the
for
head?
a moment. Blood pressure is,
That's
So-
99 on 49, heart rate 104.
so I'll pause for a moment to sort of rationalize my thoughts, and anyone willing to sort of chime in is happy to. So I'm happy to accept the commentary. So this may be the end result of the coning event. This is your sympathetic storm that's happening. We had the Cushing's event, and now you're going through sympathetic outflow, lots of it. And you'll get a high
Sorry guys, just noticing when I'm
I've got a
looking at
cuff
the
leak.
stats
I'm
are
just going to put some air into the cuff.
Go ahead.
Yeah, stats are dropping. Stats are dropping.
That's a dropping, you're ventilating or not?
Am I ventilating? I'm troubled at ventilating.
Trouble ventilating? Pardon?
My
You're
sats are
having
going
some
down.
trouble
Is he
ventilating.
ventilating?
We are having trouble ventilating.
Okay, make sure the tubes are open, the chest tube's draining.
What are my vent pressures?
Really low.
Low.
Cuff gone, is there a leak?
There's a
Can-
leak. I
can-
put
Can I
cuff
have
in
a
the
stethoscope,
pressure.
please?
There's still a big leak.
Thanks, Rob.
My inspiratory pressures and volumes and my expiratory volumes different.
Okay, so we've got a leak.
They are.
Can we just have a peek, make sure it's not extubated? The cuff is intact,
The
is that
cast
correct?
is intact. We're still at 23 at the
Okay,
lips.
can I have a glide scope handy, please?
Yep, glide scope.
Sounds like there's ventilation, so the cuff is maybe at the cords.
Well, the volume's going in, but I'm not getting anything
And
coming
out.
out.
Okay, so this side, let's check that chest tube, please. Make sure it's open. This side is open and
Yeah,
open and tight, and it's bubbling.
Yeah, bubbling.
Nothing. Chest is moving.
Yeah.
Chest is moving
It's moving very minimally.
minimally. We
Hold
have.
my arm.
I'm just gonna bag him for a bit.
Rob, would you mind stepping into the fray with an ultrasound? Make sure
Yeah, of
we have
course.
no residual
We've done-
pneumothorax or repeat pneumothorax here, please.
How does it feel when I'm bagging him?
That looks
The
good.
chest tube is bulging. Good.
Easy pressures.
How does it feel when I'm bagging him?
Pressures are
There's not a lot of pressure.
not a lot of pressure.
Are you getting a lot of bubbling in the?
Are we getting a lot of bubbling?
Consistent bubbling?
Are looking well.
Okay.
Is there bubbling?
Yeah, is it still
Oh,
bubbling?
there
Yes,
is
that's
bubbling.
good.
Okay. So,
Do I still,
Sure.
is my
In fact,
cuff,
your
is my
cuff
cuff,
looks a little off.
pardon?
The cuff on your endotracheal tube looks a little funny.
cuff, oh,
You blew the
cuff
pilot
is
valve.
blown.
You blew the pilot valve.
So, had a peek.
Well, I've got
It's
an
in
emergency pilot
place.
valve replace kit. That's what I would go get.
So,
Mark, I've got sliding
that's sliding
bilaterally.
bilaterally, okay? And the tube looks in good position.
So we just, the pilot balloon is done.
It's done.
Yep.
Very good. Can I have the tube exchange, please?
Tube exchanger.
Oh, don't worry. Okay, just pretend we'll go without it. You've got a good airway. Oxygen as best you can. Give me, must that do it in real time?
There's a tube exchanger available for you.
No, we can go without it. Do we have a starting?
You want, or you can use whatever you want.
Just start 810.
No. The tube
Okay.
exchanger over and.
We got one. It's all good. Okay, through. Unique's got a plan. Okay. You good? Got it?
Yep.
Got it?
Scissors.
That's 84.
Nu går ni rösta, det är klart.
Any of the mannequins
Who knows?
Ja, mannequin.
The ICU nurses would
Don't
know
do that.
where.
The ICU nurse bring your silent chairs to the silent.
Everyone respiratory under pressure.
Oh gosh.
That's perfect.
Come back a bit and.
There we go. No. This is typical mannequin. It's just turning around like so. Just stop that noise in the background there.
So pause those alarms. Almost.
Do we want to,
I need a start.
do we want to bag them up again,
Well,
or,
Yeah.
Ward RT from NRGH Floor 1 Nursing.
Go to, can I get a starlight, please?
Hey there, can I come up for?
And I'll bag him up.
I don't think we have a stylet.
Bag,
Seeing
please.
as there's no stylets in this particular ICU. Amazing! Woo! We rock! Yay!
Holy moly.
Holy moly, indeed.
Okay. So.
2060.
What do we do about all this?
And we'll meet you all there. We'll just leave everything as is and clean up after.
Thank you, folks.
Yeah.
Oh, there.
No.
Okay, just, we're still broadcasting, just so you know.
Okay, perfect. For all the docs in the room, just as a reminder, this is an accredited evening. So for specialists, you can log this under self-assessment activities, under an accredited simulation activity. For the family physicians, you can use this as the Royal College accredited Section 1 points.
Yep. My name on there.
So you said this is self-learning or group
So-
learning for Royal College?
It's the Royal College accredited one.
Yeah, but it is certified.
No,
through-
the other one.
Oh,
the one.
oh, for that one.
That one.
For this one,
Yeah.
it's the Section 3.
Section 3.
Accredited simulation activity. And that's where the self-assessment form comes in handy. If you do spend some time on your own thinking about this, making changes to your department, planning, those hours can actually also count for Section 3 credits under practice assessment. So it's like 3 Section 3 hours. So we haven't really done any debriefing at all, even though we've now had 2 hours of sim. So we're gonna play a game, and there are some rules. So the rules are that we're gonna continue with the chaos, and anybody is allowed to interrupt anybody else. You're allowed to go on sidetracks and just ramble if you think of something that came up that's interesting, that you want to point out. Anybody that has any crisis resource management observations would be welcome to put that out there. And everyone in the room has to say at least one thing. Those are the rules. So just, we'll just go through the stages. So emerge. From where we were, we couldn't really see the interaction between the wife and you, Alice, as a social worker.
Well, part of that was we were trying to hang back from the mic, and even when I tried moving into a position because you guys were getting ready to go, it really interfered with the mic. I ended up writing, like, this is what's happening. But interestingly, we would not have brought family into that situation. There sort of is this bizarre sort of line. If you're fine, we'll bring you in, or if we start CPR, we'll bring you in. But when you're really sick, it's too chaotic, and they're firing so many questions. And we kind of came in really suddenly. So we have a spiel that we do in the quiet room before we bring someone in. And so I didn't have a chance to do that because, of course, we wanted to see what was going on, right? So we kind of came off to the side. But when they're like doing such a serious case, we don't actually bring the I know it seems bizarre until they start doing CPR. And then we say, this is what's going on. We do allow families in there. Would you like to come in? And so there's very good research on the benefits of families being in the room when you're resuscitating a loved one. But it's so chaotic and loud, and the acoustics in that room are not that great. So typically, I wouldn't have family in there in that scenario. But what we would be doing is going back and forth and back and forth and back and forth. This is what we're doing. And our role is not to tell them what's wrong, but to tell them what they're doing. So I call it being specifically vague. And so they think they're being told all this information. And I said to a student when he came out, I said, what did I tell them? And she goes, oh my God, you told them nothing. like, yeah, as in terms of, what they found and but they get told what we're doing. And that seems to give them a little bit more comfort, and I know what's happening. And then we get them to bedside. And then any information they give us, we have to take it verbatim, and we have to tell them everything, even if we are very sure it's not relevant, because we, as social worker, we can't filter. right? It has to go
I
as
did wonder in the moment on reflection of that situation, because I did find you wrote the note down for me, and then I was looking for a good opportune time to pass that information along, and there really wasn't a good opportune time. However, I do feel like in looking at this situation, the moment that it crossed my mind that maybe this would be a time that we would invite the family is right before we took them out of the room, whisked them off to the OR. I sort of wondered if that was the moment to have the family member come in and say.
And that's typically when we would do it.
Yeah.
Because I would have come in and I said, okay, you're going to the OR, because we usually do it when they go to CT or when they go to the OR, right? Because if they go to CT and then ICU, it's gonna be another 2 hours, hour and 45 minutes, 2 hours before they get to bedside, right? So that's when we typically do it.
And normally here, one of the docs would go out and speak to them in the quiet room before bringing them into the trauma room.
Yeah, like either then or afterwards. Like typically I get my IRFs to do it because the specialist has come in. Sometimes the specialist has chatted with them, but not a long time because they're going off to get things ready, or they, they've talked to maybe the patient maybe briefly to the family, but the IRF, once the patient's gone, the IRF has time to sit down because they're relaxed because the patient's gone. They can spend 10, 15 minutes with so often they've talked to the specialist is gone, patient goes, and everyone can sort of take a deep breath and sit and talk and get their brother on the phone, and we can spend 15, 20 minutes. It's not usually that long, but so these guys are really used to, even though the patient's gone and under somebody else's care, to sit and chat with the family.
And as the wife, I did get updates, and so it was very involved that way. I got updates from both Martha and I'm sorry, Rob. So there was a presence. It was just not maybe seen in the scene as much. Yeah.
And part of that, we were trying not to get too close to it, because we talked about that too, because we were outside, and she said, well, maybe you need to be inside so they can see it. But I mean, not having multiple cameras, you can't really do it that way, right? And like we have rules that they can't go to bedside, they can't ask a question, unless the team comes to them, because otherwise it would be chaos, right? They'd be running up to, we want to hold their hand, right? That kind of stuff. I've had a family member call the code. She said, no, we're done, tell them to stop. And the team just was like, what? And I think if Dr. Flesher had done, I got more to do, he would have said no, but he said, okay. She said, no, you've done enough, we're done. Yeah.
Patients do that in ICU, families do that,
yeah.
In an ideal world where you have tons of staff, allocating a physician just to deal with the family is always nice, but there's a 0% chance that we would have, or even during the day, there's no chance that we have enough staff to
Well, and I
do that.
didn't realize that there wasn't social work at night. That was something that is, because I was saying, well, where would you guys go with the patient at night if we took them to the OR? I mean, we have an area that probably couldn't. She's like, we're not here, which is.
Yeah, Victoria had callback, and we were trying to say, well, look, Victoria got it, and then they canceled their callback, so we don't have a case for it anymore. But like typically, we sort of given them a spiel, and we kind of keep them up to date on going back and forth. And when we have a story, usually we stand and just wait for the IRP, and we say, well, tell me when you're ready for a story, because sometimes we have information what happened before, and then the IRP will just wait, and we just stand there until they're ready, right? And we have, and that's when he would have gotten the, the drugs and the medical.
I think also the fact that he was on nothing is, like, that information can wait. I would hope that if Raylene got a note that said that he was on apixaban, that would have been handed to me sooner.
Yes.
But so it was relevant information, but not emergent information.
Yeah. No, and sometimes the family give me this, like when the patient's sick, it gives me this whole like scenario, and then we're fairly, adept at knowing what is important and what isn't. Like if they tell me an allergy, like penicillin, I go, I'll be right back, right in there,
Do you want to keep going with these?
Well, I just randomly threw them.
Yeah.
So,
okay. No, that's good. I'm happy to.
Yeah.
Okay. No, go ahead. Something on your mind.
Well, the MHP was called in Emerge. Any comments or thoughts?
Okay, I'm gonna try to minimize profanity in this, but this is something that I've been here almost 2 years and I never realized this, and I think it's because our blood takes so long to get to the emergency department when we call an MHP that we're never past the initial box, like the initial product. The fact that we have to order ongoing product is absolutely bonkers.
So to clarify, the first MHP order set, you have to indicate how much you want as well.
Which is also insane. Like, that is 20 years behind the rest of the world. Like,
Is that
so,
what they do in Winnipeg?
A lot in the trauma bay.
Yeah. Okay.
like, there should be a box 1, there should be a box 2, there should be a box 3.
Yeah, and unfortunately, this has been an issue that like we
Since
did this.
2013.
Yeah, like we've been doing this for a while, and this scenario. Some of you guys were in this scenario. We did this before COVID, and we talked about even having pre-ordered
Just
blood
so you
where
know,
we
I'm
like.
just putting Dr. Muir on the phone.
That's awesome.
This has actually happened in real life too twice this week with the MHP where I had to clarify with 2 different
Hi,
number
Dr.
shots.
Meunier.
I feel like we're just used to it.
It's Sarah.
Yeah, we've adapted.
So you're on speakerphone, and I just turned up the volume. So I don't know if you were able to catch those last few comments about.
I just heard the beginning of the MHP discussion and how it's not good that you have to continue to order ongoing products.
Yeah, so I know that we've done a lot of work on pre-registration and emergency supply of red cells, and I know that that's coming. But I think that the whole process needs to be revamped. Like that is.
I 100% agree with you.
Oh, totally, and I know.
It's in progress.
Perfect. Because that's so much bandwidth for the TTL to pick what products we need next.
I trained in Edmonton, and we had a very protocolized MHP, and we are working towards that. As you all know, it's a million projects, and it's on the list. So it is working its way up the priority list, but ideally we're looking to have kind of a preset initial order, kind of a cooler or pack-based kind of system, so that it takes that cognitive load off of the clinicians in that moment. So 100% agree, and it is something we are working on.
That's great, thank you.
Can I ask a follow-up to that? Do you see, when that is protocolized, do you see that looking like we would still receive a phone call from you when the MHP is ongoing, or does that kind of roll into that automatic protocolized?
So I kind of judge my phone calls and my involvement depending on how things are going. And I think that's kind of what my colleagues do as well. We don't like mandate a phone call. I would highly recommend reaching out at any time. And then if there's any, if I get the first set of blood work back and it looks all fine, I might not get involved, right? But in the background, I'm talking to the lab a lot. So, if for an example, Nanaimo doesn't have a huge stock of platelets, if I see something's going south, I'm like moving platelets up from Victoria or, doing things like that in the background. So I'm always going to be called and involved in the background to various capacities depending on how things are going. And I often do try to check in at least once or twice during kind of these worst cases.
And I also noticed that it was halfway through the OR before the fibrinogen got there, which is something that I asked for essentially when I arrived.
I noticed that as well.
And I've spoken to Jennifer Duncan about this, and unfortunately there's been a lot of changes in the ED at the moment, so it hasn't gone too far. But apparently Nanaimo is the only site that reconstitutes fibrinogen concentrate in the lab as opposed to in the trauma bay.
That's partially correct. So we are moving fibrinogen concentrate reconstitution out of the lab as we can. So far at several sites, including like the Jubilee and Vic General ORs, and I think Emerge now, it's reconstituted bedside. And we're trying to roll that out. We have had some issues. We've been trying our absolute hardest to do that at Nanaimo, and we've been met with resistance. So that is something we absolutely want, and
Yeah.
if anybody wants to help us champion that and get that going, we have been trying and we have been told no.
So Danielle, I'm gonna send you, it's Rob Tractor, I'm gonna send you an email, because I've talked with Jen Duncan a lot about this.
Yeah,
And there's a bit of background, so I'm gonna email you about this if that's okay.
Yeah, for sure.
I'll just weigh in as well. It's Robin Roger, one of the other Emerge docs, and one of the sticky points in our initial resuscitation is sometimes actually the very first delivery of packed cells, of red cells, sometimes is really, really, really slow. Like we recently, a few months ago, had a hemorrhagic shock patient who actually lost their pulse, secondary to a gunshot wound. And it took us 20 minutes to actually get any red cells, even though we called the lab the minute the patient rolled in the door, because we had a pre-notification. So I was just wondering if there's any moves being made to get closer to having blood in the trauma bay, or at least having a really, really expedited process to getting them to recess.
So we've started a pilot project of like pre-registration emergency red cells, which is basically the ability to pre-register the patient in Cerner and have blood getting ready in the lab so that the second they arrive, it can go out the door. And it's been going really well at Vic General, and I think Nanaimo might be the next site to get that. So hopefully that helps with that initial kind of uncross-matched 2 unit stat now, and then gives you time to reassess for whether you do need more, or whether you need to, that's enough, or you need to go on and call the MHP.
I think like through trauma services, the talk is this fall, either September or October.
Yeah. So it's been going really well at Vic General, so hopefully that helps to alleviate that. And unfortunately, like we do our best. We reiterate to the lab staff, like, uncross-matched red cells need to just go out the door like ASAP. So it is something that we're actively working on, reminding staff that this needs to happen. I'm not sure what the delays are. Oftentimes there's communication issues. When we look back, kind of trying to tease out like what happened and why there was a delay. But yeah, hopefully that pre-registration kind of protocol does help to alleviate that issue.
And Danielle, correct me if I'm wrong, but I think overnight we often only have one tech in the lab. Is that right?
Yeah, so Nanaimo is unfortunately the most dire site on the island for lab staff right now. And it is getting a little bit better, but there are sometimes, I think from like 2 a.m. to 6 a.m., there may be times when there is only a single lab tech and I think one lab assistant for the entire lab. So that is very tricky. There'll be somebody on call back to come in if an MHP is called, the second person can come, but it can take like half an hour for them to get in. So that initial person, they're instructed to get red cells out the door. Like, you probably won't get labs in those cases, but just,
blood draws for
the obvious priority is get red cells out the door. So hopefully we don't get into that too much. They're working really hard on improving the staffing, and I think it is getting a bit better. But yeah, unfortunately Nanaimo is really struggling for human resources in the lab.
Thank you.
Does anyone have any other comments or questions for Dr. Meunier?
Yeah, OR team or elsewhere as well.
So just at Vancouver General, at the bottom of every cooler, there's a sign that says, "Have you given calcium?"
Nice.
Which is just a nice reminder.
I like it that it's on
It's
the
on our
order set as
MHP,
well.
yeah.
It's a good reminder.
Which is like, as someone who's like not necessarily as engaged with a computer in these scenarios, like it's nice to have physical things as well. Like in a trauma, like most of us don't interact with the computer as often as like people who are charting.
And can I just ask from an OR perspective, in the OR, when Dr. Meunier is calling, would that generally be a discussion with the anesthetist? Is that how? Yeah.
And then Emerge, who would engage with?
It would be one of the physicians, so whether or not that's the team leader or the TTL, or it depends on who's in the room, but it's gonna be one of the docs. So sometimes those kind of things get delegated off the team leader position, like if Robbie, because then you get pretty sucked into a phone call, then it's pretty hard to see the big picture. So in general, that would be how it would go. But often I think it is the team leader is my.
Danielle, do you have any other comments for us or anything to add?
No, I think we touched on most of it and most of the points I was, thinking of. Yeah, I understand there's chaos, and so I do try to pick and choose my phone calls, because I know that it's not always easy to take a phone call. So, if we're calling, it's usually because we have something to add or to say or to suggest. So, yeah.
Great.
Thanks very much.
Thank you very much for supporting us all evening and for bearing with all of the video.
Yeah, no worries. It was good.
Yeah, great. Well, thank you
It's been a
once
while
again.
since I've been in that room, right? So
You can see all the chaos in person.
Yeah.
Perfect. Well, thank you. I'm going to hang up now.
Okay.
Thanks, Daniel. Cheers.
So before we wrap the ED component of this, the last piece on here, which I think is always a super valuable kind of discussion piece, is the communication when other teams show up in the trauma room. So from whether or not that's the TTL, that's less of a handover because in this situation, Rob's also an emergency physician, but when the ICU shows up, or ENT or surgeon or anesthesia or something, those handovers and discussions about leadership are always kind of interesting discussions, and even just how to pull people in and what roles people fall into. So I'm curious if anyone has any comments on the different teams that arrived in the trauma room at kind of staggered times.
I'll jump in. For me, I would like to know that there's a chance of me being involved in the patient's care. I often get these cases when the surgeon books a case. It's like, oh, there's a E1 neck fash. Oh, there's a E1 ischemic something, and I think I would have liked, like, hey, heads up, there's a super sick patient maybe coming your way. Do you want to come down, take a boot? And I know what to anticipate and tell my OR resources, like, these are the things that we're going to need, and let's get it set up while we get the room set up. Like, I think that would help my work a lot. I don't know if my colleagues agree. I know we're often busy, but I would definitely prioritize the sickest patient in the building, obviously.
And just to add on to that, like as an OR nurse, having as much extra time to prep, because sometimes we have like a ton of stuff that we need to prep. And when it's the patient's in the elevator coming up and we're trying to scramble things together, it makes it a lot more difficult, so
can I make a comment? So I totally agree, that's 100% relevant. If I said the words trauma respond, would you guys know what I'm talking about?
we would know that something has been activated downstairs, and usually like our charge on the evenings and stuff, we'll call down or someone will pop down to try to.
And that's great, because that's exactly what's supposed to happen. So that's part of the reason why we implemented our two-tier trauma system.
And they're quite quick to actually repeatedly, like I do find that within moments, the CNL from the OR is usually
So we have a two-tier trauma activation system, which obviously in this situation we didn't use because we didn't page. But so we have a trauma alert, which is a first-tier response, which is an ED only. So if the patient has a major mechanism but doesn't have anatomic or physiologic criteria, there's a flow chart, then it's an ED only response, so the rest of the hospital doesn't know about it. So with the...
So it does not get paid over.
So it does not get paid over, it's just in the emergency department. So a trauma respond is a hospital-wide
warning.
Is a hospital-wide response, and that's why we page that overhead, because those are the patients.
Isn't that word?
Trauma response, adult trauma responds
Is this a
ETA
new
to,
thing? Cause
no.
I've never heard that over.
It's
here.
been
at least
last year.
About a year.
Yeah.
And
So anytime you hear
No, I know that. I
trauma
didn't
get
know that.
paged
It's really
overhead
good.
anywhere in the hospital, it would be a trauma respond, because the alert
And
does not.
so this was a process that me and a lot of people put into place. There's a 25-page clinical practice guideline, there's a flow chart, all of the specialties were involved with this. The heads of all of the specialties at the time were involved with it. And that was what we were trying to accomplish with that hospital-wide page. There was a lot of resistance to things like pagers or getting phone calls at home with pre-notification. But if you are in the hospital, so during hours, and you hear trauma respond, that means that there's a high likelihood, so the patient has a high mechanism, has anatomic or physiologic criteria, so a high likelihood of needing these other services, needing to go to the OR. And what actually happens is the OR is supposed to go on hold, which is why the charge calls down after 10 minutes saying, do you think that you need us? And we say, no, this patient's going to the CT scanner, keep going. Or we'll call up and say, yes, this patient's coming. So, and I've definitely, like, Seb's come down to the emergency department when he hears trauma respond. I've had Martha come down when she hears trauma respond. ICU often comes down. I've seen Mark come around. So it is meant to be a hospital-wide notification.
The only thing I would say from the operating room side of things, that you guys maybe should know is that when we're in the room.
Probably doesn't get paged
doesn't
in
get
the
paged.
operating room.
You have the same problem with
Honestly,
trauma.
unless
When you're
Yeah.
actually in the trauma room,
Yeah.
you can't hear the page. You have to ask to see if
Yeah.
it's off. It's a huge
I'm
problem.
very
And then-
open to suggestions on how we can overcome
Maybe
that.
that's why I've never heard it before.
Yeah.
Just to interject there, it's
Yeah.
kind of a double-edged thing, because if we're in the OR and we hear trauma respond, we're not actually like really able to
Totally.
to leave and come down to the
Of course.
But, you know, it would be nice to be like, okay, if we're finishing up now, it's a good
Totally.
time if things are still going on downstairs,
But like the
Yeah.
charge nurse should at least know, right? So it seems like
Yeah.
potentially like in the middle of the night, there might be an opportunity to at least make sure that someone in the OR is actually aware rather than relying on people hearing
Mm.
over.
And if it's during the day and Connie's there, that she 100% does that,
Yeah.
our problems with evenings and weekends is that sometimes the staff that's on, because on a night shift, there's only 2 OR nurses, some of the staff that's on has been in charge once or twice, and so,
It's very inconsistent, I
it's
would
For
say.
sure, and it's the same in the
Yeah.
emergency department as well.
This sounds like, by the way, the interruption rule is super hard to employ. I'm just gonna say,
I don't think it's that hard to employ.
this sounds like a really good idea. And not everyone in the room knows about it, and you're a whole, super connected crew. And maybe like everything else that gets implemented, you can't just do it once. So this probably needs some ongoing refresh, remind,
For sure.
and maybe even some refinement. Because it sounds like there's some limitations to it, like, this is super important.
And some of the refinement is OR specific because of the tools of the trade that are required. The trauma response is such it's a very vague term. It means there's something bad that's happened to some poor bugger. The rest of us really don't care. Life goes on. But we got a few of them got 2 nurses at night. And they got to get a whole pile of toys ready for the
Yeah.
surgeon. It's quite demanding. Martha excluded. No. That's the reality of an OR environment. So any priming of the operating room, I would advocate for.
And
I
I would-
don't know what that means. It has a system impact for sure. It also impacts us as individuals because I don't know what Karen's practice is like or your practice is like, but I'm in-house. I can tell you that maybe 50% of my colleagues are not in-house. So if there's a priming to be had, that's the priming, to say there's someone coming like yesterday, because there's bad things happening.
So we talked about automatic notifications, and that was shot down pretty hard.
Sure.
But if anyone in this room has ideas, like, please let me give you my phone number and email address. I would love to hear suggestions on how we can make this process better. Because I think what we're doing is light years ahead of what we were doing previously, and I would love to continue to make the process better. So please bug me at any time about this.
and my message to going back to like the OR group, nursing in particular, will be to anybody who's in charge when they hear that, not to be afraid to go downstairs, find who's in charge and say, what's happening, do you need us?
Or call the trauma bank.
So
So
One thing in the evening, especially in the evening,
and night shift, because we have no problem day shifts in weekdays, because, so Connie will stop the room that is near to finish, so
Yeah.
whenever, doesn't matter which room, they're gonna put it on hold, till get the response, so, but in the evening and night shift, specifically night shift, even the charger is in the room, so it's difficult to hear. So one thing that you can do is specifically call the charge nurse, because the phone's always with her and she's answering her phone immediately. She's not scrubbing, so she's answering, and call her or him.
I
So this is-
100% agree.
Yes, this is
Phone
one
call to
thing
the
that
charge
you
nurse in the
should
nighttime.
put in your protocol for the evening and night. So not in days and weekdays, but days for the weekends.
Sure.
Actually, you should do that too, because on the weekend, sometimes we are short and the charge nurse is in the room too, so it's very hard to hear that, yes. Yeah, evening, nights and weekends.
And then you can get ready to call that
directly.
second team in too, because if you're in the middle of a 3-hour
Yes,
case.
because
yeah,
she
we
has
have
to
to
call
extra
and she
staff.
has to arrange everything.
And
those
so then that's one
open.
phone call for you to the charge nurse, who can then put out all the calls that are necessary for
Speaker
the OR.
anesthesia and the whole bit.
And we're already in the room with the charge nurse, because we're already working together. It's
Yeah.
like,
Yes.
oh, what did the emerge say?
Yeah,
You're
nobody
calling
hear
back
that.
up.
Can
We're
I
calling
just
back up.
change gears a tiny bit on that? The same similar topic, but kind of goes back to what Karen said about having more information and kind of being involved. How often do you have, if you aren't able to come down because you're in a case and you can't get down, how often do you have one of the emerge physicians come up with the patient or give you, or a phone call handover?
No.
And I'm like guilty as well. I don't think I've ever.
Yeah, and I don't know why, like, I feel like
yeah.
you guys
We
are a good
do
group
such
and
like clear
we're a
handover
pretty
with
chill
when it's with
group too,
ICU, like there's always a
Yeah.
handover when we're handing over to somebody else, but for
Yeah.
some reason, when we have somebody go to the OR, we're kind of like,
Yeah.
oh, they'll figure it out.
That's it,
And
yeah,
I
it's
don't
just
know.
like, oh, they're gone.
Yeah.
And we're like, oh, you're like on fire physically and acidotic and everything at the same time. Yeah, it's a problem, and it's gotten worse, I think, with lack of resources, because oftentimes a porter takes the patient.
Yeah.
And we're like, then I see the person, it's like, oh my God, like, you came with a porter. So
And we're often like we're also on fire as well.
Exactly.
We
I know,
can't
and I've gone
physically
down to
come
get
up, but-
patients myself,
Yeah.
and I realized, like, yeah, of course, this person is, you know, like, so I don't really know, because it's a whole system thing, right? And then you have a patient that is, you know, the trauma, like the SIM, that literally takes all of your hospital resources. Because if that person lands in our operating room tonight, we can't deal with the obstetrical hemorrhage. Like, we won't really have, you know, so.
Maybe we should.
That
treat,
trauma would have taken our whole staff.
Yeah, exactly, and
Yeah.
our whole staff,
Yeah.
right?
Yeah.
Maybe we should just reframe it as a physician to physician transfer. Right?
Well, and
So-
that- And I'm actually shocked and disappointed that it doesn't happen, because it's like that's something that I do every single time. If they're completely stable, then no, I don't necessarily. But if they're unstable, like I don't know if anyone in the room was involved with the gentleman.
100%. You're the only physician that's ever accompanied. I've taken like probably 3 or 4 in the last like 6 months, and they've all just been with you. You're literally the only one.
So the guy that's involved himself with some stationary.
The original version, yeah.
Yeah, so he was my patient, and I was standing beside him when he did it. So, it should be default that the physician accompanies the patient. So I apologize that that's not happening.
The TTL is an additional person, right? Like you don't have.
Yeah.
Like it's not even always going to be an emerge doc necessarily going.
Soon it
forward.
won't. At the moment, it's essentially is,
And
except
I
for
would
Brian.
say
But at some
you
point,
are
like, that person
welcome
will always
in the
come.
OR to stay.
Yeah, really
I
should.
think the TTL
Yeah.
is the most likely person that would
Yeah.
be able to easily
Yeah.
come up because
don't
that's
have
their
any other
probably
patients.
only
Yeah.
patient that they need to deal with, so they could come up. But as an emerge physician, when I've got somebody that goes up, like I've got, and at night it's one emerge doc,
Right.
and
Yeah,
so
they're
the
not coming
rest of
out.
the department
Yes.
is totally moved. So,
Yeah.
but
that's
then
the
maybe it's a
reality.
then maybe it's a phone call.
Yeah.
Although it is again tricky because, and I'm trying to play devil's advocate with my own question, but you know, I maybe have already called Martha and given her the story on what Martha needs to hear about the operating, or the general surgery problem, and then it's like, okay, now I gotta call Karen and tell her about if there's anything from a anesthesia point of view, so it's 2 phone calls,
Yeah.
but
Yeah.
for a really sick patient, I think probably should happen.
So just in the interest of time, we're gonna move on to the OR part. Any comments about what went down in the OR? So there was some resuscitation before the surgery started. And then damage control surgery. And I kind of liked how you paused, recognizing that as soon as you opened up that abdomen, there was potential for a big crash, right? So there was good communication with your team, I thought, preempting that. Any comments on the surgical end of things for a patient like this with a major spleen, intestinal, intra-abdominal bleed?
Principles of damage control surgery are that you do it, that you're controlling bleeding, you're controlling contamination, you're getting out as quickly as possible, without trying to lose too much heat. So, like ideally, we will never spend more than an hour doing that. It's obviously not often realistic, especially when it's like one surgeon and one family doctor in the middle of the night.
And an orthopedic surgeon.
Yeah, well, this is excellent. And I mean, it's very easy to pretend to do surgery, but I do think those things matter. And like, ideally, there will be a pause. Like, we should be able to evacuate the bleeding, and then hopefully you can pack and slow down the bleeding at least to give time for a catch up, knowing that when you do your splenectomy or whatever you're gonna do, you're gonna lose blood again. So, and you're also releasing potentially like the compartment syndrome or whatever else you're doing. So it's very easy to say all the words, especially when you're only in your
Well, I thought you managed that damage control surgery amazing.
Thanks, everyone's right. There's an actual trauma I'm gonna go see. Okay, called Trauma Respond if I need to.
Yeah, we can't hear the speakers are turned off.
Do you have like, are there, like in Emerge, we have a lot of target times, like DORTA, TNK times for STEMIs and things like that. Do you have a like cut to close time for a trauma lap? Is there things like that, or is?
I'd say like out of my residency, it's 60 minutes.
Okay.
It's the ideal,
Yeah.
like,
Okay. And that's like skin to skin kind of.
yeah, cut to cut.
Okay.
I think it's always a bit difficult to balance like when you are going to start operating with the like with the resuscitation. Like obviously you want people to feel comfortable, but at the same time like there is a place where you can't improve things without starting. And it's like challenging when you're not doing this often. I think so.
And how does that?
You need access, right? Like you want them to have an appropriate line and all that stuff.
And how do those decisions get made between you and anesthesia, surgery and anesthesia, in terms of like when is go time? Is it?
Arm wrestle.
Yeah, carefully.
Is it back and forth or?
Yeah, there's a lot of
Based
just.
on seniority.
Yeah. I'm older. No, I think we have a really good relationship with our surgeons, and we just come to a clinical decision together, right? Like this person was like, MAP was 60-ish, and that's good enough. So we go ahead and you just kind of prepare for everything that can happen. So that's why the lines, that's why the pressers, you know, because person's just gonna crash the moment, you know, you open them up. So that's why being able to resuscitate the person early gives me that extra wiggle room for when they get surgery, which is like, you know, while they're actively trying to die, like, and have surgery thrown on top of them, it's like you get more wiggle room for a resus, so.
And a lot of this ties into like the that preparation bit, like having that heads up, because it's so much easier to be like, okay, I have the norepi, it's already hooked up, I have the blood, it's kind of in the room where the fluids and everything, the lines are open to put in. That saves a lot of time to kind of get,
And these sims, I think, over, how many years have we been doing it as a group now? But like part of that was when we started doing them, I remember we would be practicing and then we were like, we don't know who's in charge, and so now we ask who's in charge, or, you know, things like that, and go from there, right? I think it's made a big difference for.
And you need so many hands for a case like
Yeah.
that,
Oh,
which
yeah.
is non-existent at, midnight. I have two nurses.
Well, we have two on call as
Okay,
well.
one in here.
So we have two
Yes.
in-house and two on call. But they're half an hour away, but we would call them.
Yeah.
The
Yeah,
minute
we have a
found
trauma
out.
on call too, nurse
Yeah,
that we
so
call
we would
every
call
night.
them, and if we were in the middle of another case, we'd be having to call in backup anesthesia as well, so. The more
I think
heads
that-
up.
I think that speaks to that heads up as well, because there's one anesthetist who, the nurses are getting the surgical side of the house correct. And the rest of the stuff is left to the anesthetist. And you're an N of one. So you get your lines and your drugs and the whole bit. And it's not, it's one thing, it's not a slight on the nursing staff. It's just that that's the way that the work is distributed within the operating room. And that's the way we operate on any given day. We have a nurse who helps us with the airway, or an RT or an AA at the beginning of the day, at the beginning of the case, but that's about it.
The AAs are not there at night, is there?
No. So you're, so just to appreciate that it's an N of one running a life support strategy here.
Before we switch to radiology, can I ask one more question about this? Because it kind of ties into that is, there was a discussion in the trauma room about not intubating before going to the OR. Did you guys hear that up here?
Yeah.
So, and I thought that was an appropriate discussion, and we wanted you to intubate, which is why we dropped the SATs and
Of
forced you
course.
into it, which like you guys recognize, you're like, okay, I think we're being forced to act. But I think that's a really good principle, is that if you don't have to act, but you also don't want to lose the airway en route to the OR, would that be one more thing to add to your pile of work though in the night if you got an unintubated patient that then, or you?
Patient.
I will say that there was a recent study that showed that the success rate of intubation was much higher in an emergency situation in the OR compared to emerge. So I throw that in there for what it's worth.
And I think a
But
guy,
if
Yeah.
it's, you know, if you're on the fence and are stable enough to transfer to the OR, it's probably better in the OR.
I totally agree. I really didn't want to intubate this guy in the emergency department, because if he crumps because he's hypovolemic, there's nothing that we can do about it apart from, and now we've got a patient who's in a heat trying to push him up through the elevator. So someone like this, my preference would always be trying to get them to the OR if they don't need immediate intubation. But obviously in this case, Drew's an asshole and made us intubate.
I'm not always in this case, this is all the time.
Yeah.
Let's just clarify that.
I think if you're gonna intubate someone like that, you have to just anticipate you're gonna resus like hell
Oh, yeah,
right
for
after,
sure.
because they just lose all of their tone, you switch them to positive pressure ventilation, so you better be ready with everything. Time is of the essence, obviously.
Thanks, sorry to throw one.
Yeah, no, that's perfect, awesome. So then we moved down to radiology. And at that point, the patient was pretty stable, had 2 chest tubes in, intubated, on pressors but stable. Surgery was successful. And then something else happened in the CT scanner. So I'm just wondering if you guys can give us a rundown of what happens in the nighttime or anytime when you have a code in radiology, because at least for us in the operating room, that's a huge mystery. We don't know what goes on down there.
It's a blue button.
In this situation, I think the technologist has a job to do, and that's to get good images off to the radiologist. And if the patient is escorted by nurses, it's our expectation that those nurses will be monitoring the patient's condition, and that will be up to us. So we want to get the patient on and off the table as soon as we can, so we can get back to doing all the imagery constructions, because there's radiologists, like I said, on the other end, waiting for those pictures, making diagnosis. So the
So
longer
in
we
the
spend.
nighttime, the personnel who would be with you in that room would be just
Well,
the
if
tech.
if the patient just comes from emergency with biporter, it would be by myself. And in which case, yes, I would have to monitor the
So
patient.
an ICU patient like this, though, there'd be.
Oh, no,
two-
we would like we'd be 4 nurse nurses, escort, we'd be
yeah.
emerge nurses there.
So emerge nurses, even though they're coming from the
No,
OR?
no, if they're from the
No, no,
OR.
from the OR,
If they're
we-
coming from emerge to CT, then we would be there, yeah.
And physicians or no?
Yeah, sometimes
Same as the OR,
If it was
I'd
a-
take this patient to CT
Yeah.
scan.
If it was a patient like this, there'd definitely be a doctor there. Yeah.
But coming from the OR.
Coming from the
I
OR.
don't
No,
know.
we
I
wouldn't.
think it's a good question.
Yeah.
You would, because the handoff to ICU has not happened. And
No.
this is,
But-
it's actually a good talking point, because the handoff to ICU hasn't happened. I was just I don't know, fly on the wall with someone with morbid
In my
curiosity.
experience, the sequence of events that happens tonight is not the usual sequence of events. It's usually emergency to CT to OR.
Right,
So-
yeah.
So, I don't know if that would be
Yeah.
the situation.
If there's a code called, you'd get an ICU nurse
Yeah.
running for
It
sure,
would
and
almost
probably
have
an
to be
emerge nurse would be.
handover.
Yeah,
But it would almost
emerge
have to be
goes
like an
CT.
ICU handover from like at the OR
Yeah.
down to CT.
Yeah.
I mean, like, we usually take the patient all the way to ICU, so if we're stopping at CT,
Then it
we
would
probably
be us.
would
I
be
would
with
probably
them.
stay with them, yeah.
Yeah,
But Mark came to the OR, so I'm like, bye.
Sucker.
Be with the patient. So because
But she
the
broke the endotracheal tube.
OR nurses so can monitor the patient in city. So they are not trained for that. So we are not
Right.
training for that. So we don't know what should we do. So the only person that can be with the patient is the anesthesiologist to monitor the patient. If the patient came from the OR, in my perspective, I don't know.
You're right,
Yeah, I would, someone like that, I would stay, and then if that is the decision to go to scanner, then ICU, but the reality is usually ICU has already accepted the patient and, so I mean, doesn't matter as long as the physician is there. Again, the challenge is being the only, person on call in the building, like, then I'm tied up with this person for several hours potentially, right, like in the OR and then down in the area, and so, anyways.
So I think the value of this simulation allows us to open up conversations.
Mhm.
And it to some degree sort of defines flaws in our current planning.
Yeah.
And so this gives us an opportunity to engage others like the ICU early, to say, I've got this patient, you should probably come and see them on the table. I know you don't want to see them or whatever, but they're yours. When this man stops, they're yours.
I would say that the ICU physician often comes up to the OR.
Yeah.
And
Yeah, they
we all
often
have some
do.
sort of
patient like that, they're gonna see them
morbid
anyway.
curiosity of what's coming our way.
Yeah.
Because we all hate surprises. I think I speak for the whole bunch of ICU docs. I hate surprises. I've never been a nurse doc.
Love surprises.
Centers of license, good lord, what the hell is this guy? Anyway, but, cool, and I think call us early too, from an ICU perspective. Call me and tell me you got this victim that's coming my way, and then I can plan the rest of my miserable night.
If it's trauma too, you may have already seen that person in the
Yeah.
trauma room, because you would have heard the trauma respond, but.
Right.
But again, if they're in the trailer, they don't hear that as well, so.
But they're moving out.
Yeah, no more trailer.
They're going down to
From
the
tomorrow.
basement under the ICU.
Or from-
Oh, yeah?
Oh, yeah. No more trailer. Got new digs.
It's just gonna be a little jaunt down to the OR for you now.
Pardon?
So it'll be a jaunt down to the OR for you now. You'll be there all the time.
And if this patient is ultimately going to the ICU, like we know that they've got a bed, typically an ICU bed also means they have an ICU nurse. So if we know we have to stop at CT,
Yeah.
maybe that person can come join us
Yeah.
and help with monitoring while the OR nurses like clean up and prepare for the next case.
Yeah, that's a good. So one example that how much we can't help you is we didn't even know how you are transferring the patient. You are transferring the patient with arm boards in two paws. We never do that. We are just putting the patient without the arm, without the board on there. So and it's hurting the patient apparently. I just learned that now. I don't know if my other colleagues knew that. So how you're transferring.
Are you talking about transferring the patient directly on that board?
Yeah,
and
she's
using it?
suggesting
Yeah.
that in the OR, they take
Exactly.
them off the board.
Yes.
Yeah,
And
we are
you
not
leave them
doing
on.
that.
See, that's a big learning point for me, I had no idea.
Yeah.
Yeah. So how can we, or all of us, help you guys who are super limited in the evening with a patient with IV poles and everything? How can we best assist you?
Just be observant to your patient. Don't just come to CT and just, think it's a coffee break while we do everything else.
Yeah.
You know what I mean? It's
Mhm.
we've got a job to do
Sure.
Yeah.
That's good information, yeah?
Yeah.
The other thing I might add too, and not necessarily just in an evening trauma situation, but even during the day, communication with CT is really important, because you can't assume we're just gonna sit there with an empty scanner for 5 minutes that turns into 20 minutes, that turns into 30 minutes when we've got EVTs, biopsies, PEs,
Sure.
all these urgent things. So letting us know when you're maybe 5 minutes out, giving us a phone call, giving us a chance to wrap up, as opposed to us sitting empty, idle, waiting for a patient they may or may not come in 5 minutes.
Jeff, do you think that's gotten better in the last little while from emergency? Because I know when we initiated the process, there was a lot of, maybe not a lot of, but some miscommunication where CT would say, okay, we're ready, and then emergency's like, oh, well, we just started doing something, we'll be there in 10 minutes, so you guys start another scan. They're okay, oh, we're ready, we're like, oh, we're doing something now. But my impression over the last kind of 4, 5, 6 months is that the process has gotten a lot smoother, at least in the cases that I've been involved with. Is that your impression from the other end?
Yeah, it probably has improved a little bit for sure, but I'm not sure how much of that is on our end when we're phoning and saying, just make sure to give us that phone call.
Yeah.
As opposed to.
That's good information for us in the OR, because
Yeah.
you're right, this is not the typical sequence of events, but you can see how a super unstable patient could bypass radiology first and then come to you, so.
I mean, we see 100 to 120 people on CT a day. So leaving that room empty for a period of time is just.
Costly,
Waste.
yeah.
Yeah.
Yeah,
It's affecting
it
other
costs
patients'
patients.
care.
Yeah, it costs patients, yeah, for sure.
Can I ask you about the anaphylaxis component of in radiology? So you guys have a crash cart with crash cart meds, and you could call a code blue, like especially if you're on your own.
Correct, yeah.
But it wouldn't be crazy to think that anaphylaxis from a contrast allergy is not terribly unlikely.
30
so
years
do you-
ago, it was much more common
Yeah.
than it is now.
I bet, right? So do you have any anaphylaxis meds, or is it just the crash cart meds? So just the epi, I guess.
We do have epi, it is IM epi.
Yeah.
And we have atropine.
On the crash cart, or is that?
We have it in each room, we have a emergency med room, so.
Okay.
IM epi, atropine, Benadryl.
Do you have any cognitive aids? By that I mean, hard copy, this,
We have a poster.
I've
on
seen
the
it,
wall.
yeah, I've seen
Yeah.
your guys'
is that
anaphylaxis
for
poster.
anaphylaxis or for
It's
resuscitation?
for all levels, 3 different levels of contrast reaction
Oh,
or
okay.
yeah, so
Okay.
anaphylaxis and mild to moderate reactions as well.
Sure.
What
Good to
about
know.
ACLS disorders? Do you have like an ACLS?
It's over my pay grade.
It's on the crash cart.
That's in the crash cart.
It's on a crash cart,
Yeah.
manual.
Have you guys thought about having like an anaphylaxis like kit? Like I know you have like your med cover, but an
Yeah,
actual
we have
kit.
we actually quick grab epi kit right on our door, we just
I
grab
love
it.
that. Oh,
stuff
perfect.
the
Great.
syringe, the epi and.
I mean, that is the most important
So you
part,
don't
the
have to go
rest we
digging
can just
through
grab from there.
looking for
Yeah.
drugs. I mean, you have to draw it up, we don't keep an epi pen in there.
No,
Oh, yeah,
same with
no,
us
same in
too.
emergency.
We draw
Yeah.
it a lot.
And following up on that as well, there was discussion about IM versus IV epi. I don't know if everyone caught that part, but there was IV access, there was some epi available, I'm not sure what concentration or how much it was. And then there was discussion about maybe doing IM instead of IV. I'm curious if anyone wanted to kind of share their thinking on what was happening, or somebody who's involved in that conversation.
I was,
That was Keely.
yeah. So from like an emergency perspective then, like we push cardiac epi in cardiac arrest and the patient was not in a cardiac arrest, they're in anaphylactic shock. So anaphylactic protocol like we would do right at the triage desk is to give IM 0.3 to 0.5 epi IM, and that's what we do.
Not a titrated IV, which is what I do.
Yeah. And
A
so,
syringe.
I don't think there's a right answer in this situation. I think that whoever's with the patient, like if he's got an anesthetist there who's
I got the wrong
comfortable
guy.
with, like there's no and that's the quickest route. There's no reason why you would have to draw it up and give it IM. But if that's not the case, then
Sure.
yes, in emerge we give it IM most of the time because we don't have IV access.
Occasionally an
So we
epi infusion for like refractory.
yeah. And so the epi that was being discussed to be given IV, who had that and how much was it?
It was
So
like a
there is
1
an
milligram,
epi.
10 mil, like the,
So it's put like push dose epi, like a milligram intensity?
was it the actual push dose, like where it
No,
was
it's diluted in a syringe.
diluted like the 10 mic?
Yeah.
Yeah.
Okay.
Yeah,
Okay.
because it's like our kind of resus drugs that we have,
Yeah.
like it's vasopressin, epi, so for,
Okay.
what was this?
So
10
not
mics-
the
10
actual
mics per mil.
ACLS 1
No,
milligram.
100 mics.
No.
Okay.
100 mics per
So
minute.
it would have been a titrated
Yeah.
Yeah, so you give 100 mics, 50
Yeah.
mics, and see what
Okay.
happens, give up
Yeah.
200 mics, see what happens.
I
Did
think
anyone
you're right,
hear
it
that?
doesn't, there's no right answer.
Yeah.
But it feels like a med error unless you know that there's another answer.
Yeah.
And so for those of us who were like, no, it's this is you do, IM, the alternative is like a significant PSLS event, right? And it kills people, like that was my training, right? Versus, oh no, this is what we do, we just have it on our card, it's no problem, because I've heard this, we've had these conversations
So
many
many
times.
times.
So what you're used to is someone else's error.
Every time.
Every time.
And just clarifying as well that they are totally different doses, so if you are gonna go IAV, make sure you know that it's not the same dose of 0.3 to 0.5 milligrams, it's that, so that's why I just wanted to bring that up, because it was a good back and forth, and what I really liked about that is like, there was no judgment about that conversation back and forth, it was just, wait a minute, you mean IM, right? And then they said, no, we can give it IV, and we've got IV access, let's just give it IV. And so it was just a really good back and forth, and I think as long as you know that there has to be a dose adjustment and a
I think the
discussion
other-
about that,
As long as the patient gets
clarity
the
of
IV.
what that is, yeah.
The other thing that I think was valuable about that conversation is it was a to and fro with no hierarchy.
Yeah.
Because we could have made it a hierarchy conversation,
Yeah.
like, it was my way or the highway.
Yeah.
Which would have been poor for the conversation. And that's important for these simulations and for our real life.
Yeah.
We need to flatten hierarchies, because patients come to harm if you have hierarchical structures and you make a bad decision as someone who wears the crown. So sometimes a tough crown to carry thereafter. So
Yeah,
just
to
be
me,
open to
just like
conversation.
observing that, I wasn't involved in the conversation, but it felt like clarification, it just felt like almost like a safety check, like, wait, are we doing this? Yes,
Mhm.
okay, yeah, let's go.
Mhm.
And it was quick and it was efficient.
Yeah.
It's important to level hierarchies.
So moving to the ICU.
What the hell
I think
happened
there
there?
was, there was a pretty quick recognition that there was a head injury. We knew that from the CT scans, and that there was a big problem with ICP. In fact, you kind of started managing it right in the CT scanner. Do you want to just maybe comment on treatment of increased intracranial pressure?
Sure. So the principles of managing a patient with a head injury with raised ICP follows that Monroe-Kelly doctrine. So there's limited space, there's a fixed space within a fixed cranial vault. And things change in that space. And if things change in the space, it's going to be really three things that change. It's the fluid volume, it's the tissue, or it can be a tumor. In this case, it's blood, and it's got to displace something else. And it displaces the CSF first, and that's your first response. And the next response is to displace the brain through the foramen magnum. And
That's bad, right?
Yeah, that's bad. So in order so that's the big fearful thing we've got to deal with. But in the meanwhile, while ICP is building, there's brain at risk from hypoperfusion. Your cerebral perfusion pressure is compromised, and in very simple terms, it's the MAP minus your CVP. So you would have to manage that well. So you're going to offload the CVP, so the head of the bed slightly up, and drop the MAP up, provided there's no other source of hemorrhage. And then you want to create space for whatever this blood that's taken up space. So you want to dehydrate the brain a wee bit. Mannitol, 3% saline, pick something. But mannitol's easy to give quickly. And then you hyperventilate in the hope of causing vasoconstriction. It's transient, it wears off in a couple of hours, so it buys you a little bit of time, maybe at the beginning, but not much beyond then. And then, of course, definitive surgical management. You need a flap taken off if the surgeon's going to operate. The drill, they have a flap, so you need control. Whether put the flap back or not, it's a different conversation. The body flap. Yeah, those are the principles, I think. Sedate the patient, drop
Get
the
an orthopedic
BMR.
surgeon to
He was
do it.
cool already, so you're protecting him.
Yeah. So we may have, or I may have like made that change happen a little, maybe either a little too abruptly or too deeply, because we were hoping to kind of like make that to kind of prompt that hypertonic discussion and some of those other things. We didn't actually anticipate the thought of a burr hole, but it was a good discussion and I like that it was brought up. To clarify, just because we've been doing some work on this in Emerge over the last couple of years, is right now there's only one burr hole kit in the hospital, and it's still in the big metal silver carts in the OR. But we are building one for the trauma room, but it's taken like a year to get one of the drill bits. So it's like we're still waiting, but apparently like it's coming from some factory that is backlogged on this one drill bit. So anyways, there will be one in the trauma room as well. I don't think there will be one in the ICU, but there will be one in Emerge. And we've been doing kind of semi-regular training on using burr holes for the Emerge doc. So not to say that any of us have done them, but we've been practicing with the actual burr hole kit on like pigs' heads and stuff. So not that means that we're experts by any means, but we've actually played with the kits.
Is it brace and bit or is it electronic?
No, it's a hand crank. Yeah.
Oh,
So.
Because what happens is I'm sure you've used it. You get through with a little burr, and then you put the other one on, it chatters as you make a hole through the inner table.
Yeah. So the drill bit that we're missing right now is for the inner table. We've got all of the pieces to get through the outer table, but then there's like a conical bit that goes through the inner table, and that one is supply chain issues, COVID or something. I don't know, some bullshit reason why we don't have that one. Anyway, so
there's at least one PubMed reference on using IOs.
Yeah. There is a burr hole kit in the hospital.
You'll see it in like social media and stuff. I don't know that there's a ton of. I think there's probably better options if you have them available. And it sounds like we have better options available.
And in terms of who's actually done one, because when I did a little bit of reading and asking around to see who was prepared to do this in our hospital, because it's not well done. Mike Kenyon has done one, which is probably no surprise to anyone here. Rudson Brown apparently has done one, and Chris Cameron has done one, and I think all of those were a very long time ago. I don't think any of the Emerge docs, maybe Chris Rumbaugh, but I don't know if any of the Emerge docs have actually done one, other than in our training sessions when we've been like practicing on skulls, but not on real patients. And I don't know if there's anyone else.
Most of the neurologists have done them.
What's that?
Most of the neurologists, I'm sure.
Neurologists would definitely not have done it.
In their residence?
No.
Quick question about that.
Like
They're medical.
A patient who has a suspected major like neurosurgical problem, would they not get like triaged to skip Nanaimo and go straight to?
Robbie might be a better person to answer.
So the short answer is no. There's no pre-hospital bypass from Nanaimo unless they're an auto launch. So if everyone knows what an auto launch is. So an auto launch is an automatic dispatch of a helicopter and a critical care paramedic. So let's say there's a crash at Port Alberni, they meet a certain criteria based on the 911 call, a helicopter gets launched with CCPs. And then after that, once the initial crew gets there, so the primary care crew gets there, and they fulfill continuation criteria, then the helicopter keeps going. But they can also get stood down. If a helicopter gets there and there's concern of neurotrauma, they'll go to Victoria. But by road, the patient is coming here. So if the patient is within 90 minutes of Nanaimo, by road, they are coming here. All right, so essentially like Duncan, so like south of Ladysmith is within the 90-minute window for Victoria, so they'll go down there, but everything north up to Campbell River essentially, probably maybe not Campbell River is probably a little too far.
But Comox for sure.
Comox, Port Alberni, that's all within the EHS bypass window, so they all come here. And then they can go on after that. That being said, our air resources are horrendous in the province. Like our transport system is like other things 20 years behind the rest of the world, and we have no coverage. Overnight, there is one air resource for the entire province. Oh my God. So getting this guy out for the province. So getting this guy out, like Mark asked me to go call neurosurgery. It's like, yeah, PTN, they're coming. In actual fact, we cannot get these patients out in the middle of the night. So they're gonna be here until the morning.
I guess that's why Karen brought that up though, right?
Yeah.
Why are we taking on these patients that like we?
Because where else are they gonna go?
Well, to a neurosurgery center, if you know, if you recognize.
But they
every
can't,
injury.
how are they gonna get there?
But by, if you're saying these guys are all.
But if they're coming from like Port Alberni or Comox by road at like 11 o'clock PM, they've got to drive all the way to Victoria with an unstable trauma patient, so they'll have to stop here.
So the idea is that we should be able to stabilize any unstable trauma patient and then ship them out. Like in theory, like we could do a burr hole here. If a patient had a catastrophic brain injury and a patient needed it, we can do that. But it would just be too much by road to get them, and that's why like the cutoff for going south is Ladysmith, so actually pretty close to here. But north is just too far.
Is this new since this newer onset of the trauma team?
No,
that's come up
this
here now?
is a decade old.
Okay.
I can show you the EHS. I worked with the ambulance, and I can show you
That's
the
okay.
I can show you the
It's
trauma bypass.
just
if you're-
more, I guess, we've come to know this new trauma service, and I have to say that the orthopedics team, I don't think there was too much engagement. We just kind of all of a sudden found out we're now a trauma center. Resource-wise, I don't think we have enough
Yeah.
to keep up with these big trauma cases that are coming in. And I would implore you to engage with either the leader or our entire group, because we are seeing a change in our practice based on this new trauma team starting. And we're already like, and it's not a surgeon limitation, it's probably more time limitation issue.
Sure.
It's been, we've noticed it. We actually gave some time back to deal with volume, and then we haven't elective time, and we haven't actually gotten that back now, and I'm quite sure we won't get that time back to the elective wait list now that we're a trauma service. But I think we were almost told, and we didn't realize it was happening. We actually thought it came like without us getting to have any say beforehand.
So the last accreditation for trauma centers in Canada was in like 2010 or something like that. So we've been a level 3 trauma center since 2010. I know Darren, the trauma coordinator, was looking into numbers, and there's actually not a ton of transfers in. The bypass stuff is not new either. I think the difference is that we're consolidating the patients. Like, what would happen before is that these patients would be admitted to Comox under a family doctor for 4 days, and then they realize that they're not doing well, so then they would send them down. And I think that we're noticing it because they're all in one place. But I know that there's been some discussions between like Brian and orthopedics and anesthesia. But none of the policies that we're talking about now came with the trauma service. Those are all long-standing provincial standards.
So I have a question. So say I'm like skiing Mount Washington, I hit my head.
Yep.
So I'm at Mount Washington, so I'm more than 90 minutes by road. So I would get flown to Victoria.
If there was a helicopter available.
The helicopter, if the helicopter.
So during hours, there's a crew based out of Qualicum. But because our resources are so shitty, they're often doing like NSTEMIs from Seashelt, like so if you happen to injure yourself at Mount Washington in the brief window where there's a crew available, they might get launched. Otherwise,
Is that just like our health authority, or is it like a known province-wide thing?
no, it's province
like-
wide. Province wide.
Right.
So don't go night skiing.
So there was a trauma.
Or get your loved one to take out AMA and fly WestJet to Vancouver.
So there was a trauma conference recently that I gave a talk at on trauma destination guidelines, and I put up a comparison between the service that I did pre-hospital helicopter stuff in Australia, and I put up a map of the resources in the state in Australia versus British Columbia, and there's 3 times the number of air resources that all operate with a physician and paramedic 24 hours a day. Here we have 1 overnight. It's horrendous.
That's really bad.
Yeah.
That's like really awful.
Yeah.
So just in the interest of time.
Sorry.
I know that
I
there
get
are
passionate about
like
these things.
so many more things to talk about, but I'm already half an hour over, which I really apologize for. So if anyone has any other burning thoughts that they want to throw out there, now's your chance.
Would any of you as teams practice, if this has happened, do hot debriefs on your own? Would there be a leader among you who would have?
Edie tends to.
Oh yeah,
Oh,
we
yeah.
definitely, we're big debriefers, yeah.
For sure.
Other teams? Thank you.
Yeah.
I think they do.
Yeah.
Even if they're more informal.
A little bit tricky to, obviously, when the team gets separated, like half the team goes to the
Yeah.
OR, like hard to, but yes, it would. Or we might even, sometimes we do like a hot debrief where we're just like waiting for one last thing to happen, like we might be like, let's just do like a quick hot debrief while we're waiting for the CT to get ready, or we're waiting.
Even
for
when there's like recognition of
When the patient's still
of even recognition of the next day, the need for a debrief for some staff, because there's lingering questions, often we'll arrange after too.
Thank you.
That was awesome, guys.
Yeah, that was so good.
Thank you so much for everybody coming and participating.
Aspirin neurosurgeon.
I'm sorry, everyone in the emergency department's already used to how much I talk. Most people.
Control.
The
I
idea
think
with
that's
our
a priority
verbals
though,
is
we need to be comfortable.
have a neurosurgeon on the phone though when you do it.
We do it, we're doing it, basically organizing it every year to do a training session every year.
Like I used to work at the Foothills on their neuro ICU step down, and we did it at the bedside like at least 4 times a week.
We luckily have not had one in an IMO in like over a decade.
They just had one in French George.
As soon as you get the equipment, you will.
Yeah.
Just be itchy
I don't know,
to
I
do
think
it.
we made it to Vancouver eventually.
Thank you so much.
Thank you, Sarah. Thank you, Drew.